Om Swastiastu. Assalamualaikum warahmatullahi wabarakatuh. Shalom, Namo Buddhaya, greetings of welfare, peace be upon us all. Ladies and gentlemen, welcome to the 13th Annually Bali International Combined Clinical Meeting 2026. So today here we gather for the third day of the event, and it is an honor for me to stand before you today as we gather for this momentous scientific event. First and foremost, let us express our praises and gratitude to the presence of the Ida Sang Hyang Widiwasa, the Almighty God, for it is by His grace that we gather here for today's lecture. First of all, I'd like to introduce myself. My name is Surchan, and I will be guiding the proceeding on today's event. Before we commence, I would like to extend the greetings to our esteemed teachers, so the invited guests who have this moment. We would also like to express our deepest gratitude towards our sponsor, Etika. So now please give a round of applause to Etika. Today, we are going to hear an in-depth discussion from our guest lecturer, our visiting expert, Dr. Anur, Dr. Kim Osborne, Dr. Cassandra Discol, who has traveled all the way here to share their expertise with us. And also here we have also Josephine, who's come along. Okay, and also our beloved teacher, Dr. Tjahya and Dr. Herdita. And first of all, welcome to Bali, doctors. We hope that you enjoy your time here in this beautiful island. And please, once again, join me in giving a heartfelt round of applause to welcome our lecturers. We will now proceed to the highlight of today's program. Our main scientific sessions today will feature 5 highly relevant topics in today's anesthesia practice. Without further ado, please let's invite our first lecturer, Dr. Tjahya Aryasa. Please give a big round of applause for Dr. Tjahya.
Terima kasih Sucan. Once again, thank you for coming, Dr. Kim, Dr. Anu, Dr. Cassandra, and your team. Once again, thank you for your support, my department. Today, I want sharing knowledge about obstetric anesthesia. Jadi adik-adik residen, beliau adalah dokter yang bertugas di Adelaide di Australia. Dr. Anu, Dr. Kim sudah sering datang ke sini. Ini adalah BICCM yang ke-13. Jadi kita sudah melakukan Bali International Combined Meeting itu sudah ke-13 kali. Sekarang tolong dimanfaatkan. Nanti silahkan diskusi apa yang Anda ingin ketahui, apa saja tentang anestesi obstetrik. Saya akan, topik pertamanya nanti dari saya, Dr. Anu, Dr. Kim, dan Dr. Cassandra. Dr. Herdita juga belum datang, tapi nanti akan menyusul. Saya akan menjelaskan sedikit, I'm speak with bahasa, aliran darah Uteroplacental. Ini basic obstetrik anestesi. Yang pertama, prinsip dasarnya adalah Uteroplacental itu adalah aliran darah ke ibu, yang tujuannya adalah untuk mensuplai, kemudian mengeluarkan zat-zat yang tidak diperlukan ke janin untuk dibuang ke ibu lagi. Itu intinya, itu konsepnya. Ini agak jelimet ilmunya, tapi mohon didengar. Sirkulasi Uteroplacental itu bisa dipengaruhi oleh kondisi ibu. Penyakit ibu misalnya kencing manis, nanti ada istilah gestasional diabetik, kemudian bisa preeklamsi, kemudian dipengaruhi juga oleh obat, dipengaruhi juga oleh persalinan. Nanti tanya, kita di sini tidak terlalu sering melakukan painless labor, tapi di Adelaide wajib. Kalau di sini kita biasanya ibu dengan kelainan jantung baru kita lakukan, atau ada indikasi medis yang lain baru kita lakukan. Kalau di tempat di Adelaide wajib, semua persalinan normal wajib, Kemudian gangguan Uteroplacental itu ada istilahnya great obstetric syndrome. Ada 3 di sana, ada preeklamsi, ada IUGR, ada prematur. Ya, gangguan uteroplacenta itu menyebabkan ketiga penyakit yang terkenal ini disebut dengan Great Obstetric Syndrome. Kemudian ibu hamil itu tidak bisa digunakan untuk penelitian, untuk teman-teman yang melakukan penelitian, karena dia populasinya khusus, etiknya tidak lolos. Jadi dasarnya biasanya uji binatang. Ya, uji binatang. Tolong diingat itu, datanya di uji binatang. Sementara binatang itu, spesies yang digunakan biasanya itu adalah domba atau pengerat tikus biasanya digunakan. Itu sirkulasi uteroplacentanya beda dengan manusia. Ya, jadi sering pengetahuan yang diberikan tuh berubah-berubah tergantung dari hasil penelitian yang terbaru. Jelas ya, mudah-mudahan saya jelaskan pelan-pelan. Nah, perbedaan spesiesnya apa? Ternyata dia beda. Ya, kalau plasenta manusia bersifat hemokorial, dia langsung, ya, ibu dengan fili koronik janin itu bersentuhan langsung, direndam. Sementara yang kalau di domba itu epitel korial, jadi ada pembatas. Bedanya di sana. Jadi kalau diukur obat di bayinya domba sama di bayinya manusia itu pasti hasilnya beda karena ada pembatas di sana. Ya, itu. Jadi kemudian ada remodeling. Remodeling itu perlu sampai lebih dari 80% perubahan arteri spiral itu. Perlu sampai 80% untuk persalinan yang normal. Sementara di tikus remodelingnya sedikit. Nah, dari dasar-dasar karena perbedaan spesies itu, implikasi klinisnya hati-hati. Ya, implikasi klinisnya hati-hati. Karena yang seperti saya sebutkan, di spesies hewan sama manusia itu beda. Kemudian ini anatomi aja. Anatomi suplai darah uterus itu jalurnya dari arteri uterina, kemudian bercabang-cabang. Yang paling harus diingat adalah arteri uterina ini paling besar. Dia bisa berdilatasi sesuai dengan umur kehamilan. Ya, jadi itu yang harus dipelajari, diingat-ingat kembali, ini tentang anatominya. Nah, terjadi perubahan aliran darah uteroplacenta itu, dia ada fase-fasenya. Ya, fase 1 sebelum implantasi dikendalikan oleh estrogen dan progesteron. Kemudian di bawahnya lagi nanti dia kemudian terjadi proses remodeling. Ya, harus ada remodeling. Kalau enggak remodeling, bayinya prematur atau preeklamsi. Ya, atau IUGR. Kemudian yang ketiga baru ada vasodilatasi dari arteri uterina. Makanya tadi arteri uterina udah besar, tambah besar lagi. Baru nanti janinnya akan sehat. Itu prosesnya ya. Agak jelimet ya untuk dokter muda. Ya, nanti bentuknya seperti corong terbalik. Ya. Jadi kecil, ini spiral, kemudian dia corong terbalik. Harus begitu bentuknya. Ya, alirannya besar, tapi tekanannya harus rendah. Ya, dan anehnya lagi dia tidak dipengaruhi oleh sistem simpatis kita nanti kalau sudah hamil. Jadi ibu tensinya naik, bayi belum tentu. Dia cuma tekanan saja. Ya, saya lanjutkan. Jadi selama kehamilan, ya, terjadi proses invasi trofoblast, yang mana namanya invasi trofoblast dok. Nah, nanti yang gambar selanjutnya ini, ya. Ini adalah 3 skenario. Ini normal, non pregnant. Ini eklamsi, kemudian ini adalah normal pregnancy. Ya, harus ada invasi dari sel trofoblast sampai ke DC2. Kalau yang hamil kan tidak ada nih. Ya, tidak ada, cuman bentuknya epitel-epitel saja kalau yang non hamil. Kemudian kalau dia preeklamsi, trofoblastnya itu nembusnya cuman di basal DC2 saja. Ini yang bawah ini yang arteri spiralnya tembus oleh DC2 itu sampai 80%. Ya, ini yang diukur sama obstetriknya. prediksi untuk preeklamsi ada tidak. Ini yang diukur. Jadi kemampuan nembusnya namanya conversion fraksi. Ya, kemampuan nembusnya ini atau dibandingkan dengan tebalnya ini namanya conversion fraksi. Itu yang dilihat pada saat ANC. Kalau dia kira-kira invasinya kurang, silakan Dr. Rita. Kalau invasinya kurang, berarti prediksi untuk terjadi preeklamsi atau nanti prematur atau IUGR nanti dia, ya. Jelas ya? Nah, aliran darahnya itu jadi peningkatan. Jadi peningkatan aliran darah uteroplacental terutama berasal dari penurunan resistensi vaskuler arteri uterina. Ya, dari kira-kira 5 menjadi 0,5. Ya, jadi kita bisa lihat di sini dia ya jadi penurunan resistensi. Artinya dia melebar, tekanannya ini baru bisa alirannya itu masuk. Harus ada invasi yang sampai 80%. Baru normal lahirnya. Ya, baru suplai oksigennya bagus. Jadi ada tiga faktor yang menyebabkan pertumbuhan janin itu bagus. Yang pertama harus ada remodeling vaskuler. Vaskulernya harus berubah bentuk, mulai bisa lurus, bisa lebar, supaya bisa invasi ya. Kemudian perubahan aktivitas dari vaskuler. Yang selanjutnya adalah dilatasi arteri spiralis. Itu proses 3 itu harus jalan baru bayinya sehat. Baru sirkulasi uteroplacentanya bisa bagus. Nah, kemudian setelah terjadi dilatasi, ya, remodeling dan baru terjadi redistribusi ke pelvisnya lebih banyak. Aliran darah itu lebih banyak di sana. Makanya kalau operasi seksio risikonya berdarah tinggi karena pembuluh darahnya pasti lebar. Ya. Tekanannya juga di sana ditoreh sedikit, biasanya bleedingnya banyak. Jadi itu yang menyebabkan aliran darahnya pooling ke sana, ke daerah pelvis. Kemudian ini adalah rumus yang biasa kita gunakan, ya, di mana aliran darah uterus tergantung dari tekanan perfusi uterina dibanding resistensi vaskuler uterina, di mana tekanan perfusi itu rumusnya MAP uterina, MVP uterina dibanding resistensi vaskuler. Ini adalah beberapa kondisi-kondisi yang bisa menyebabkan penurunan uteroplacental blood flow. Ya, tinggal dihafal. Kemudian bagaimana caranya ngukur? Ini tugasnya Dr. Robjin. Biasanya menggunakan Doppler, ya. Kemudian yang dihitung misalnya rasio sistole diastole, pulsatil index, kemudian RI atau indeks resistensi. Ini tugasnya teman-teman Obgyn. Tapi sekarang anestesi sudah bisa, sudah senjata. Dulu mata kita adalah stetoskop, sekarang mata kita mulai bergeser ke ultrasound. Jadi jangan merasa ultrasound itu barang yang terlalu mewah sekarang, sudah banyak, sudah beredar, ya. Tapi bukan berarti di mana-mana gendong ultrasound, ya. Kalau stetoskop kan bisa dibawa, ya. Nah, kontraksi uterus dan apa konsekuensi terhadap janin? Apakah kontraksi uterus itu bagus? Ya, tapi harus ada proses selanjutnya, proses persalinan. Kalau dia belum matur, belum cukup bulan, kemudian kontraksi, masalah. Ya, makanya Dr. Obgyn memberikan obat anti kontraksi, disebut apa biasanya? Tokolitik biasanya, ya, dikasih tokolitik dia supaya kontraksinya, karena kontraksi itu ternyata mengganggu sirkulasi. Setiap kontraksi, ya, aliran darah itu akan berkurang ke janin. Ya, dilatasi lagi, baru dia bisa jalan lagi, ya. Kemudian kontraksi lagi, aliran darah akan menurun. Nah, kontraksi ini nanti, Dr. Sindri silakan. Kontraksi ini kalau pada bayi yang normal, plasentanya bagus, bisa terkompensasi. Tetapi kontraksi ini akan terganggu pada pasien-pasien dengan masalah plasenta, misalnya insufisiensi plasenta, ya, dan penyakit yang lainnya. Jelas ya, maksudnya begitu ya. Jadi selama kontraksi itu terganggu penurunan, tapi terkompensasi kalau bayinya sehat. Jelas ya? sorry ini ya. Jadi konsekuensinya apa? Kalau tidak bisa terkompensasi, ya, denyut jantungnya akan menurun, kemudian bradikardi, asidosis, kemudian dikatakan ada bisa menyebabkan ensefalopati hipoksik. Ya. Kemudian yang pemahaman keliru itu ternyata cerebral palsy itu bukan dari kontraksi. Jadi memang ada pertumbuhan yang terganggu. Kemudian bagaimana perubahan selama persalinan kontraksi itu? Jadi kontraksi normal saat persalinan mencapai 40 sampai 100 mm Hg. Selama relaksasi uterus itu bisa ada aliran lagi. Kemudian terjadi autotransfusi lagi. Ini bukan bayi lahir ya, ini autotransfusi di sela-sela kontraksi itu. Nah, ini bermasalah ke ibu-ibu yang memiliki kelainan jantung. Nambah 500 cc itu, hilang lagi 500 cc, nambah lagi itu masalah. Ya, jadi proses persalinan pada ibu dengan kelainan jantung hati-hati. Ya, persalinan normalnya maksud saya ya. Atau postoperatifnya juga hati-hati. Kemudian saya bahas sedikit tentang Great Obstetric Syndrome. Jadi preeklamsi, IUGR sama prematur itu prinsipnya gambar yang tadi ya. Jadi kalau dia invasi tromboblastnya tidak bisa sampai 80%, preeklamsi dia. Atau bayi lahir prematur atau bayi pertumbuhannya kecil. Jadi itu yang berhubungan dengan sirkulasi uteroplacental. Mudah-mudahan bisa nangkap ya. Bisa ya, saya pelan-pelan. Kemudian obat anestesi pengaruhnya bagaimana supaya teman-teman adik-adik yang menginduksi, kalau general gimana pengaruhnya. Jadi kalau kita lihat di sini tiopental, propofol, ketamin, etomidate memiliki efek langsung yang minimal. Jadi selama ini masih aman. Tidak tahu nanti ya akan berkembang. Kemudian tapi dia memiliki efek tidak langsung. Misalnya respon simpatis karena intubasi laryngoskopi. Ya, pada saat itu hati-hati, uteroplacenta akan terganggu. Efek simpatisnya yang ini makanya harus dalam ya. Dr. Raju mengajarkan kita kalau preeklamsi bagaimana cara intubasinya, tetap kasih fentanyl. Sekarang Dr. Anu intubate with general anesthesia in pregnant woman, you use opiat and then intubasi laryngoskopi untuk mencegah simpatisnya melonjak. Ya, nanti kita tinggal berkomunikasi dengan neonatus bahwa kita menggunakan opiat, dia little bit sleep sedikit ya setelah menggunakan opiat ya. Kemudian volatil bagaimana? Volatil digunakan boleh asal MAC-nya diatur. Ya, jangan lewat 2 MAC, gunakan sedikit, dia tidak terlalu menyebabkan kontraksi dari uterus. Cuman tergantung MAC ya. Kemudian neuraksial efek langsungnya tidak ada, tapi efek tidak langsungnya ada, tapi dia punya efek kalau simpatisnya sudah terganggu. Misalnya vasodilatasi, hipotensi, pengaruh ke neuraksial yang kita berikan. Habis spinal, hipotensi itu ngaruh ke bayi. Ya. Kalau lokal anestesinya langsung tidak, ya. Kemudian vasopresor, pilihan yang terakhir adalah phenylephrine. Tapi sudah mulai ke kelompoknya adrenalin lagi. Kita lihat nanti perkembangannya. Dulu kan epidrin. Ternyata epidrin itu bisa menyebabkan lewat ke barier plasentanya lebih tinggi. Ya, kemudian metabolismenya meningkat. Kemudian asidosisnya meningkat. Ya, blood sugarnya berubah. Jadi metabolismenya yang ditingkatkan karena efek epidrin yang lewat ini. Jadi pilihannya sekarang adalah phenylephrine. Tapi lihat, kalau saya menggunakan phenylephrine, saya lihat nadinya, karena kita harus tahu efek samping dari phenylephrine itu apa. Dia agak sedikit predi, hati-hati. Ya. Kemudian analgesia neuraksial mempengaruhi kontraksi uterus. Ya, jadi kalau konsentrasinya bagus, dia ritmenya, kontraksinya akan lebih sering. Ya, lebih sering. Karena efek dari vasodilatasi tersebut. Tapi kalau sering-sering, kalau bayinya bisa mengkompensasi aman, kalau tidak mengkompensasi bayinya bisa asidosis, hati-hati ya. Jadi mainnya di mana? Mainnya di konsentrasi obat ya, supaya tidak terlalu berefek vasodilatasi. Kemudian obat tambahan aja, obat antihipertensi, intinya adalah bukan memperhatikan janinnya, tapi perhatikan sirkulasi ibunya. Target MAP yang kita targetkan misalnya untuk preeklamsi adalah di bawah 140 ya, sistolnya itu yang diperhatikan. Apapun yang digunakan untuk antihipertensi selama ini masih dikatakan cukup aman atau bisa digunakan. Kemudian terapi oksigen yang baru ya, jadi yang baru yang terkini itu dilaporkan kalau ibu itu saturasinya cukup ya, perifernya cukup, terapi oksigennya tidak perlu. Guideline-nya di AKOG itu sudah merekomendasi, tapi walaupun masih kontroversi ya, kalau saturasi ibu itu bagus tidak perlu suplai oksigen karena bisa menyebabkan iskemik juga di aliran darah bayinya. Jadi kalau dia oksigennya bagus tidak perlu ya, itu yang baru. Kemudian vasopresor yang lain-lain sudah saya jelaskan ya. Jadi ada phenylephrine, ada ephedrine, kemudian ada sensitivitas vaskuler berbeda. Maksudnya begini, ibunya ininya pengaruh ya. Jadi di sirkulasi ibu pengaruh, di sirkulasi janin belum tentu. Ya, di sirkulasi ibu simpatisnya berpengaruh, di bayi belum tentu. Itu beda ya. Kemudian inotropik begitu. Jadi yang kalau keadaan emergensi yang diperhatikan adalah keselamatan ibunya. Terakhir, ini adalah Uteroplacental adalah pelajaran fisiologi dasar, harus dimengerti buat teman-teman adik-adik residen yang melakukan pemberian anestesi, harus ngerti sedikit kapan dia bisa mempengaruhi sirkulasi ya. Kemudian harus ada remodeling arteri spiralis, perlu 80% lebih supaya sirkulasinya bagus. Kemudian pemantauan klinis, datanya itu percobaan binatang, sementara percobaan untuk manusia akan tidak lolos etik. Kemudian anestesi obat-obatan, anestesi unilaksial dapat meningkatkan atau menurunkan aliran darah uterus, itu hati-hati. Langsungnya tidak, tapi dia tidak secara langsung. Kemudian eksplorasi hewan itu maksudnya percobaannya semua di hewan, ya, percobaannya semua di hewan, sehingga aplikasi ke klinis ke manusianya harus perlu hati-hati lagi. Jadi ilmunya selalu berkembang seperti itu. Ya, saya kira itu yang bisa saya berikan. Saya berusaha menyampaikan secara sederhana, mudah-mudahan bisa. Kalau mau belajar lagi silahkan dibaca-baca lagi. Terima kasih.
Okay, thank you so much, Dr. Tjahya, for the lessons. Okay. Okay, now we will move into our next session. We have our visiting professor, Dr. Anuraju, visiting lecturer. I'm sorry, yeah, lecturer, Dr. Anuraju. So now we will hear the lecture from Dr. Anuraju. Please, the time is your doctor. Please give a round of applause.
Om Swastiastu. Assalamualaikum warahmatullahi wabarakatuh. Shalom, namo buddhaya, salam sejahtera bagi kita semua. Is it pagi or siang? Siang, selamat siang. Apa kabar? Baik, ya saya senang sekali datang ke Bali, kembali ke Bali dan bertemu dengan kalian semua. Terima kasih banyak Dr. Tjahya dan departemen beliau untuk mengatur konferensi ini dan undangannya yang baik dan keramatamahannya. Saya tahu apakah Anda kalian semua memikir sekarang bagaimana orang India ini berasal dari Australia, berbicara bahasa Indonesia. Karena itu saya sudah sering datang ke Bali dan Indonesia dan mulai tertarik dengan bahasa Indonesia dan mengikuti kursus singkat di dalam bahasa Indonesia dari Australia. Tetapi bahasa Indonesia saya sedikit saya masih siswa sedikit sekali di dalam bahasa Indonesia dan bahasa Indonesia saya tidak bagus atau kurang baik untuk konversasi yang formal. Oleh karena itu saya melanjutkan presentasi saya di dalam bahasa Inggris as modern techniques and technology in high risk obstetric anesthesia. Right. So first things first, thank you very, very much for yesterday and having us here and having a wonderful fun run last night. And how good was yesterday? Like, who's best? Is your saxophonist here? There he is. Good man, well done. You blew everyone away. How good was yesterday? And having us around yesterday, so it's fantastic, all right? So thank you so much for having us and entertaining us yesterday. So it's very, very, very good fun. As far as modern technology is concerned, we've come a long way. 5 years ago, 10 years ago, we wouldn't have any idea of what we can do with our phones. So what we can do with our phones and things. So now we've come a long way from what we have, especially the last 5 years with the advent of AI. So sort of follow a case of a primate who's 39-week gestational diabetes with a BMI of 57 and distress in labor. It's a high-risk case, isn't it? So I thought of putting a bit of technology in it and ask AI to come up with a picture of this patient. And there we go. You got a patient and AI has generated an image of this patient. And we will call this patient Ibu AI or IE or whatever. So let's follow this patient. So this patient is distressed in labor. She needs pain relief. So what are our options? So options are, Neuraxial is the best form of anesthesia. As far as anesthesia is concerned, pain relief is concerned, Neuraxial is the best form of pain relief in labor. So our options are epidural anesthesia, which is supposed to be the gold standard. I don't have to tell a bunch of anesthetists how long an epidural anesthesia is going to take. It takes a little bit longer. It's not instantaneous. But the good thing is a catheter can be inserted and we can continue the anesthesia for longer. Analgesia for longer. And then there is a spinal anesthetic. It's a single shot. It's very quick, but it's wears off quickly. Then you can combine the best of both worlds. You can have a combined spinal epidural where we can give a spinal anesthetic, get them comfortable quickly, and continue with the epidural anesthetic. But the problem is, when you get them so quickly, we got a bit of an imbalance of hormones. So when you are uncomfortable, you have adrenaline in the circulation. The patient is laboring, so you got oxytocin in the circulation. Oxytocin contracts the uterus, while adrenaline relaxes the uterus. So if you take the pain away completely with the neuraxial anesthesia, there is an imbalance between oxytocin and adrenaline, and then the adrenaline level plummets. You can get unopposed uterotonic activity with oxytocin, leading on to early profound fetal bradycardia. About 5 to 17% of cases is what the literature says. But even though it's theoretical, it's quite self-limited. It goes by itself. So that sort of prompted people, because of that fetal bradycardia, we need to go a little bit more slower. So that's when the advent of a dural puncture epidural came in. So the dural puncture epidural is nothing. So it's just a combined spinal epidural. In a combined spinal epidural, we put a needle in the epidural space and pop a needle in there, and then we put some medication in. That'll get the patient comfortable. But in dural puncture epidural, what we do is just like a combined spinal epidural. We put a needle in there and make a hole with a spinal needle, and no medication is injected. So what happens there is the epidural medication from here will go through this hole into the subarachnoid space and cause the patient to be comfortable a bit more quicker than the epidural, but not as quick as the spinal anesthetic. So that's that's what we see as like the literature shows that like the hole, if you create a hole with a needle with more than 24 gauge 25 gauge, that medication from the epidural space can go in the spinal space and cause so that's been there for about 10 or 15 years. So we'll look at how effective a dural puncture epidural is. So there was a recent meta-analysis which came last year, which shows comparing epidural anesthesia with a dural puncture epidural, which definitely shows that the DP is much more faster than an epidural. So it's a busy slide, so everything, the money is down here. So I'll just blow that up and we'll see what happens. So it gets quick onset of analgesia. Unilateral block, sacral sparing, motor block is less likely with a DPE. So DPE is definitely better than an epidural analgesia. So how about comparing DPE, dural puncture epidural, with a combined spinal epidural? So there was another randomized control trial that came up last year. Mind you, there are lots of QR codes in my talks, and if you scan those QR codes, that will take you straight to your article, or I can download it in your phone. So there are lots of QR codes that you might come up later. So if you are interested in that article, just scan those QR codes. So this is a randomized control trial of CSC versus dural puncture epidural, which says there is no significant difference in the quality of labor analgesia, but the pain scores are significantly lower in the combined spinal epidural than a dural puncture epidural. So it came up with an editorial saying that the anesthetist should adopt a patient-centric approach and embrace the CAC than a DPE, and that's what it stays for the time being. So this would be a patient. You need to do an epidural in this patient. All right? How are we going to do an epidural in this patient? Can be quite tricky, isn't it? So what does the modern technology goes? We have an echo, all right? So echo is good in these patients where you can have ultrasound. And we spoke about this yesterday, so I'm not going to much detail about ultrasound scanning. There is an article if you want to scan, which will take you through how the step-by-step process of how to do an neuraxial, how to do echo for a neuraxial spinal. Longitudinal view, and then you get the so you get a view like this. So we get the lamina going posterior ligament frame. This is a sacrum, lamina, ligament frame, lamina, ligament frame. In artist impression, it looks like a sawtooth, and that's what you do. And you count the level from down, and you come up, and then you turn the probe around. You get the spinous process, and then you go in between the spaces. You get the it just looks like, you get the articular processes, the transverse processes, the ligamentum flavum, and in artist impression, it looks like Kelelavar Terbang. Right? So you can see flying bat over here, isn't it? This is the ear of the bat, this is the wings of the bat, the forehead of the bat, nose of the bat, and that's what we see here. Right? So those are the two views that will give you an idea of how to do this. And then when you get an idea, just draw a cross, and then X marks the spot. And remember the angle of insertion of your needle. So that's another modern technology that sort of brings us to closer to doing this. So, but by end of the day, sometimes it might look like this. You wouldn't have absolutely no idea of what this is. Like, where is your gigi gargaji, or where is your flying bat? You won't be seeing anything. So that's when the modern technology is going a step ahead, and there is AI incorporated into ultrasound. And so it will mark you and gives you, and this tells you this is the sacrum, this L45, L5S1, marks the midline and everything, and it's going to make your life easy for you. And we're doing a trial at the Women's and Children's with the AI ultrasound, and so that's sort of a future that tells you how easy technology can make for you, because it will mark things for you and tells you what is what and which is which. So mind you, this is the first ultrasound machine. You can see how cumbersome it is, how you can see the whole thing. And now the modern technology is developed into handheld. You can have it on your phone, All right, you can have the probes, you can have it on your phone, and how easy the modern technology has moved out to. So this patient gets another epidural with an ultrasound. And it's another AI-generated image. You can see that's why you mustn't blindly believe in AI. Someone's giving a blood. You can see someone's giving this patient blood. I asked the AI to generate an image. There's the blood being given. I can't see the patient's legs and stuff. So, but it's a bit tricky, but it's so funny. Anyway, and then she gets a patient-controlled epidural analgesia with a PIEB, or programmed intermittent epidural boluses. And that's the gold standard of labor analgesia these days. So you know what a PCEA is. PCEA, every time the patient wants, they can press. So to explain PIEB, we'll just go to a scenario where we're giving 5 mils per hour of a medication versus 5 mils per hour or 5 mils every hour. Is there a difference? 5 mils per hour, the patient's getting 5 mil every hour, isn't it? 5 mils per hour and 5 mils every hour. Is there a difference? So to look at that, 5 mils per hour is, you get a drop and a drop and a drop and a drop. All right? It just goes there and forms a puddle just near your spine line. Like it just forms a small puddle. But in actual fact, the medication has to spread. So this is your spinal anesthetic, and this is all these yellow things, the epidural space. You have the fat and you have the blood vessels and all those things. So unless until the epidural goes around all these area, you're not going to get good pain relief. All right? So that's when your 5 mils every hour comes in. So you give 5 mils every hour, it just goes as a gush. All right? So that goes as a gush of fluid every hour. It goes in there and cause a good spread of local anesthetic. So that's why every hour you give programmed intermittent boluses. You program it in a way so that you get a gush of medication going in on top of that. So we do use dilute local anesthetic of low concentrated solution, and we use a property called synergism. All right? So, and the local anesthetic, we use 0.1% ropivacaine with 2 mics per mil of fentanyl. And this is the pump that we use for giving the medication. So to explain synergism, this is calapaperut, all right? So calapaperut, it's calapaperutus enac, isn't it? So you add that with a bit of gula java. So calapaperut is enac, and gula java is enac juga, isn't it? So when you combine both calapaperut and gula java, you get something which is like that, which is enac sekali, isn't it? It's a bit of calapaperut and so and when you make that dadar gulang, it becomes luar biasa, is it? So similarly, you put a little bit of local anesthetic and a little bit of opioids, and what we use is 0.1% ropivacaine, all right? And a little bit of 2 micrograms per mil of fentanyl, and that becomes a very, very potent solution, all right? So that's what we use, so that there is not, and this is what we use. We use 0.1% ropivacaine, 2 mics per mil of fentanyl, and this is a cheat sheet. We have it on our drug trolley, and was developed by Kim Osborne. He was the head of the department. 2014, almost 12 years. It has stood the test of time, all right? So 10 mils every 20 minutes, that's the PCEA component. And then we have 5 mils every hour. So that's your PIEB. That's a program. Every hour you get that 5 mils of gush going in. That's a PIEB component. And the patient also can get another 10 mils from the midwives. Just to get that. So this is our order for PCEA. In our hospital, and what we can see, what you're using, 0.1% ropivacaine, very, very dilute local anesthetic solution. The patient won't get any motor block, but gets a very, very good sensory block. So patient can still move the legs, and 2 mics per mil of fentanyl solution is what we use. All right, and nowadays the technology has gone a step forwards, depending upon it's integrated, depending upon the patient's demand. The machine would adjust itself, like, it adjusts its bolus and lockout interval and all those things. And it's done by Dr. Tjahya, which most of you are going to meet in Solo. He's one of those pioneers who's developed a computer-integrated PCEA. And remifentanil is also catching up as a medication, as a first. Some of the hospitals in the UK give remifentanil as a first choice, or one of the choices for labor analgesia, because it's very, very potent. It goes quickly, wears off quickly, all right? So very good for labor pain, which sort of doesn't stay there for long. But the problem with remifentanil, it's a very, very potent opioid, and it will cause respiratory depression and respiratory obstruction. So people were a bit worried. So people are getting more and more confident with using remifentanil. And nowadays there are computer integrated remifentanil PCA, which monitors your respiratory rate, your SpO2, and increases and decreases bolus, lockout interval, and all those things. So those things are coming up in the market, and that's developed by Dr. Tjahya as well from UK. So our patient is comfortable. So she gave us some, gave a good neuraxial anesthesia. Our patient is comfortable, and all of a sudden, sooner or later, the patient had a baby. Happy days. And unfortunately, our patient had a bleeding. So I asked AI to have a bleeding patient, who's the same patient having bleeding and distress, and this is what the computer generated for me. You can see the surgeon stabbing the patient and making the patient bleed, all right? So, so anyway, this patient was bleeding and unfortunately needed a general anesthetic, all right? So, so nowadays we have difficult airway society guidelines. Very, very important. Registrars can sort of scan that. Very, very important document. It's very, very good document, which will take you to difficult airway society guidelines for obstetric patients, and it's very easy to follow. And one of the things that I have to emphasize is the ramped up position. All right, so not just in obstetric patient, any patients, you can do this. So ramped up position means you are, so when you have a morbidly obese patient, the head just hangs off the pillow. So you know the oral axis, pharyngeal axis, laryngeal axis, all those things, isn't it? Of the airway. So the laryngeal axis is looking inferiorly. So if you were to intubate this patient, the tube the larynx is looking like that. You're invariably making your life more difficult by putting a tube from below. So that's where, if you have an imaginary line between the ear and the sternal notch, this notch, so you ramp the patient up until that line is absolutely parallel. So this line was like that. That's an imaginary line from the ear to the sternal notch. The patient, it was like that in this patient. So you put pillows and whatever and have this like that. And you can see how the laryngeal axis has changed. The larynx is looking, previously we had to intubate like that. Now the tube can go in like that. So it makes your life easier for you to intubate these patients. So that's where the ramped up position comes up. So to get more oxygen in, we use high flow nasal oxygen. If you don't have high flow nasal oxygen, we can utilize just this ray tube. We can just connect it, put 15 mils. It's a study done from Australia. Connect our normal oxygen outlet in there, and then have high flow oxygen going through that, all right? And that gives good apnea time. This is a study that they've done. Even in, say, about 20 minutes, the patient was, sorry, 15 minutes, the patients didn't desaturate. All right, so consider face mask ventilation was a no-no beforehand. Second generation laryngeal mask makes your life easy, and video laryngoscopes as well as used. And those are the modern technologies come up in obstetric anesthesia. It's making lives easy for us and for other patients as well. So patient starts to bleed, have to give back blood. What do you give back blood? There can be two types of bleeding, bleeding with coagulopathy and bleeding without coagulopathy. With coagulopathy, you need to give blood. Without coagulopathy, you give blood and blood products. And one of the things that we do for give bloods is intraoperative cell salvage. You utilize the patient's own blood and give it back to the patient. So what we do, we collect the blood from the patient and we mix it with some anticoagulants, and that gets, we sort of store that blood there, and that blood is cleaned, centrifuged, and given back to the patient. All right, so so the problem with this is you get only clean blood cells, and you still need platelets, FFP, and plasma. So only red cells can be reinfused. So we still need other medications for coagulopathy. All right, so this is the blood cell salvage machine that we have in our hospital, and these are a variety of cell salvage machines that we have available in the market. All right. Interest of time, I will just quickly swift through. Rotem, we had it's just a talk in itself. It definitely tells you what to give, and this is a critical bleeding algorithm. We use a ROTEM guided bleeding algorithm, so we know what products. ROTEM tells you what to give, all right? Rather than blood, if it needs FFP, it tells you lots of, I'm not going through too details in this. One thing to remember in ROTEM is, if you have to remember one thing in ROTEM, try to keep your FIPTEM A5 more than 12. If it's less than 12, we need cryoprecipitate. All right, that's one thing you need to remember, ROTEM. If the patient has hypotension, Cindy was talking yesterday about point of care ultrasound. We can use that to look at this is a normal parasternal long axis view. It tells you how the heart's functioning, whether the problem is due to hypovolemia. So if you have hypovolemia, you can see this is the inferior vena cava. Your inferior vena cava is collapsed in this patient. So this patient is well filled. This patient needs more volume. So that tells you what to do. So this patient, this is normal ejection fraction, and this is a hyperdynamic heart. You can see lots of space in here, but we need filling in this patient. It tells you what to do in these circumstances. And this, you can't see, like, can't even see any contraction in here. So that means a severely reduced ejection fraction. You know the problem is mainly a pump failure. Patient might be having a heart attack or something like that. And you can see over here, there is a clot moving in the RA. That means that patient is having a pulmonary embolus. So that may be the clot which is moving in the right atrium. And when that happens, the right atrium is going to get dilated, and it'll push the right ventricle is going to get dilated, and they'll push the left ventricle on this side and gives it a bit of a D sign there. Minimally invasive cardiac monitoring and all those things, which hypotensive productive index, all those things are quite newer. And in interest of time, I'm just going to skip, and so is enhanced recovery after cesarean section. So to summarize, safe high-risk obstetric care makes us, it's mainly comes down to proactive anticipation and real-time techs, where we have the second-generation neuraxial anesthesia, ultrasound-guided DPE, PIEB, advanced monitoring with POCUS, ROTEM, and things like that, and protocolized care with video laryngoscope readiness and multiple protocols. So before I stop, anesthesia is very pretty small specialty. We started probably 179 years ago, and this was the guy who was an obstetrician who first developed anesthesia, labor analgesia with chloroform, and that used handkerchiefs, all right? So to see where we have come. And remember, these guys used to research like this, all right? This is how they researched chloroform and ether. So over dinner parties and on themselves, and they survived, they didn't overdose, and now, so that's good in a way that we have moved so far from the 1840s to now, where technology and technique must converge to manage complexity. Makasih banyak. Our patient was discharged home, luckily. Matru Suksma. And you take the questions at the last, or when? After everything. Okay, cheers. Makasih.
Thank you so much once again, Dr. Anu. Give him another round of applause. Yeah. So we will have the discussion. We'll have the discussion session later on. Now we're moving to the next lecturer. We have our own Dr. Herdita. He will also present an interesting topic for all of us. Okay, Dr. Herdita, the floor is yours. Please give another round of applause.
Halo, good afternoon Dr. Anu Raju, Terkim, Dr. Cassandra, glad to have you here. Oke, untuk teman-teman, saya Dr. Herdita. Mungkin saya akan membawakan, kita pakai bahasa Indonesia ya. Untuk saya, kita akan membawakan tentang manajemen anestesi pada kasus-kasus preterm. Ya. Untuk slide-nya, oke. Sebelum itu gini, kenapa sih kita perlu belajar ini? Mungkin saya sering masang CVC pediatrik. Ada beberapa yang pernah ikut masang CVC pediatrik akan disuruh sama senior atau chiefnya untuk bagging pediatrik. Kenapa sih kok bagging pediatrik itu sering sekali desaturasi? Padahal baggingnya masuk. Waktu ketika kita bag kasih pressure, dada pasien tuh ngembang kok dia gitu. Tapi kenapa sering sekali desaturasi? Kenapa konsulen kita minta yang paling senior untuk melakukan ventilasi? Padahal bagging itu kalian semester 01 pun mengerjakan. Nah, kenapa pada pasien-pasien bayi kecil di bawah 2.500 itu yang senior yang diminta? Karena dia ada suatu perbedaan dalam kita tata cara untuk melakukan anestesi manajemen pada neonatus, terutama yang preterm, gitu ya. Jadi kalau misalnya dia neonates biasa, mungkin kalian kompensasinya masih lebih panjang. Tapi kalau yang preterm itu pasti ada tata cara yang berbeda, gitu ya. Jadi ya makanya kita perlu mempelajari ini. Next, oke. Kenapa sih gitu? Karena satu, neonatus itu dia berisiko 5 kali lipat mengalami komplikasi dibandingkan yang tidak prematur itu dulu. Yang kedua, ada beberapa fisiologi yang belum berkembang. Itu namanya kenapa kita growth and development. Kita manusia itu kita bertumbuh dan berkembang. Neonatus bayi itu bukan miniatur orang dewasa. Dia mungkin belum bertumbuh, ukurannya dia lebih kecil, tapi development itu berbeda. Development itu artinya ada berkembang. Di suatu ukuran yang sama dia berkembang. Ya, jadi ada growth and development. Jadi neonatus itu dia perlu waktu untuk growth and development dari parunya, heart jantungnya dia, brain, metabolik dan yang lain-lain. Setelah itu juga kita harus pikirkan brainnya. Dia memiliki matriks germinal, ya germinal matrix. Tahu nggak germinal matrix? Germinal matrix itu bagian di otak yang menumbuhkan saraf di otaknya dia. Jadi kan bayi-bayi itu sarafnya dia belum tumbuh semua. Jadi ada satu daerah namanya germinal matrix di mana dia diam di sisi ventrikular. Ya, jadi dia itu di sana dia berkembang waktu kita jadi janin, itu yang buat kita punya saraf, kita bisa berpikir, kecerdasan kita tumbuh dari sana. Jadi selama dia perlu berkembang, dia perlu dapat support yang baik. Itu kenapa pembuluh darahnya banyak, pembuluh darah banyak gampang pecah. Itu kenapa kita sangat sering menemukan IVH pada kasus-kasus neonatus. Itu ventrikular, dia letaknya di dinding ventrikular, itu namanya germinal matrix. Itu yang harus kita pikirkan bagaimana, makanya kita sering, kenapa sih N2O tuh di KIA, di pediatrik tuh harus hati-hati. Bius preterm menggunakan N2O, kenapa harus hati-hati? Bagaimana penelitian N2O terhadap neurotoksisitas, ini hubungannya. Brain vulnerability-nya dia. Jadi membius neonatus tuh bukannya miniatur orang dewasa sekali lagi ya, jadi dia berbeda gitu. Yang ketiga adalah rising survivor. Jadi semakin berhasil hidup bayi kecil di bawah 2.500, semakin sering kita akan mengerjakan ini. Dan selayaknya harusnya semakin banyak yang bisa bertahan hidup gitu loh. Jadi kita semakin sering, dulu mungkin saya tidak pernah mengerjakan bayi di bawah 1.000 gram atau 1 kilo, tapi sekarang kan udah sering. Di bawah 1.500 apalagi udah sering banget. Jadi dengan berkembangnya obstetri, anestesi berkembang, bayi bisa lebih kecil lagi dilahirkan gitu. Jadi sebagai anestesi yang dapat pediatrik kita harus bisa belajar ini. Oke. Harus tahu dulu prematurity. Mungkin ada yang udah sasa pediatrik ditanya sama dokter putukur, apa itu PMA? Corrected, yang mana dipakai? Prematur itu ada dari umur, ada dari berat, yang mana dipakai? Apa sebutannya? Itu harus tahu dia. Gestational age itu dari kapan? Dari pertama menstruasi sampai lahir bayi. Setelah itu chronological age. Kapan dia waktu lahirnya dia? Oh, dia bayi berumur 1 bulan, itu chronological. Kalau ditanyain gestational age, dari kapan dia menstruasi? Jadi hari pertama menstruasi dihitung dari usia kehamilannya dia, digabung. Setelah itu adalah post menstrual age, PMA. Itu ya gestational age ditambah dengan chronological age. Jadi kayak misalnya kita ngomongin apnea of prematurity. 60 minggu apa ini? Chronicalnya. Apa PMA-nya? Nah, kita harus tahu dia mendefinisikan risiko terjadinya apnea of prematurity, harus tahu age yang mana kita mau pakai. Ya, standar itu yang kita pakai adalah post menstrual age atau PMA. 60 minggu adalah berapa usia dia dilahirkan, berapa minggu dia usia dilahirkan, tambah usia setelah dia dilahirkan itu. Itu kita cari 60 minggu. Di bawah 60 minggu risiko terjadi apnea of prematurity gitu loh. Jangan nanti 60 minggu itu berapa ya, bagi 4-15 bulan, oh bayinya setahun umurnya ini masih ada apnea of prematurity gitu. Nah, ngitungnya salah gitu ya. Jadi harus tahu definisinya. Oke. Next. Nah, apa aja sih operasi-operasi yang sering akan kita temui pada pasien-pasien dengan kondisi preterm ya? Yang pertama, inguinal hernia. Hernia inguinalis dikerjakan oleh bedahnya dengan laparoskopi. Pada pasien yang preterm itu double masalah sebenarnya ya. Kita tahu parunya dia belum berkembang. Nanti kita bahas di belakang kenapa sih kok gampang banget desat pasien-pasien neonatus yang preterm itu. Setelah itu dia menggunakan invasif, menggunakan laparoskopik. CO2 dimasukin. Apa sih efek CO2 pada pasien-pasien yang preterm neonatus? Dengan kata dibalik kata minimal invasif. Ya, it's not so minimal invasif laparoskopi, apalagi pada preterm neonatus. Setelah itu neck. Ya, karena bayi-bayi yang lahir kecil dia dipuasakan, dia tidak bisa bergerak bagus ususnya, otomatis fili-fili ususnya, bakteri tidak berkembang dengan baik, ususnya bolong, perutnya kembung, ditusuk keluar gas. Ya, itu operasi neck. Nah, ligasi PDA ya wajar ya. Umur di bawah usia yang seharusnya itu pasti resiko PDA yang nggak nutup dengan spontan. Habis itu ROP, retinopathy of prematurity. Teman-teman mata sering, dia harus ngeleser matanya, jadi minta sedasi biasanya. Ada pasien-pasien bayi prematur diminta sedasi. Ataupun tindakan kita juga bisa memicu terjadinya ROP, pasien baru lahir prematur operasi, ternyata dia neck, kita operasi. Setelah itu kita karena sering desat pasiennya, bayinya desat dipompa terus dikasih oksigen 100%. Teroksidasi dia retinanya jadi ROP. Jadi harus ada tindakan kedua lagi dari teman mata untuk mengevaluasi. Ya, setelah itu yang terakhir lah nih obstruksi. Ya mungkin di sini banyak banget kasusnya, mungkin kita lihat pasien-pasien yang dia ada duodenal atresia, anorektal malformasi, gastrosisis, itu banyak yang tipe-tipe obstruksi. Ya, jadi kasus-kasus seperti ini akan kita sering banget lihat pada pasien-pasien dengan preterm. Nah, apa aja yang beda? Banyak bedanya, tetapi yang perlu diperhatikan pada preterm itu yang pertama adalah impaired brain autoregulasi. Ingat, dia otaknya masih setengah jadi otak. Jadi regulasi sistem dalam tubuh itu masih setengah. Penggunaan obat harus dipikirkan mana yang toksik terhadap neurologinya dia, mana yang masih bisa dikompensasi oleh dia. Limited cardiac reserve, dia heart rate dependent. Ya, dia otot-otot jantung tuh belum seperti orang dewasa yang bisa meningkatkan kontraktilitas. Dia benar-benar pure dari heart rate dependent. Yang ketiga, regulasi. Bagaimana brown fat masih meregulasi sebagai thermal regulation dia, sedangkan pada bayi-bayi yang sudah keluar dari tubuh ibunya, dia harus berusaha membuat suhu tubuhnya terjaga sendiri. Setelah itu metabolisme obat, bagaimana fungsi ginjal, berapa persen dia, bagaimana kemampuan dia membuang natrium, nah itu harus tahu. Sama yang terakhir nih, kenapa ini paling besar, immature lung. Ini masalah pertama kita bius pasien-pasien yang prematur. Next. Ya, ini. Respiratory fisiologi, secara teori gitu. Fisiologinya dia, ya kita tahu semua FRC slow, high oxygen consumption gitu. Tapi bagaimana caranya neonatus mempertahankan nafasnya dia? Ada 3 mekanisme yang berbeda dari orang dewasa. Yang pertama, otot dada ya. Dia menggunakan otot dada horizontal, bukan vertikal sirkuler kayak kita orang dewasa. Yang kedua, untuk mempertahankan alveolusnya tetap terbuka, dia akan melakukan auto PIP. Bagaimana cara kita membuat auto PIP? Dengan memperpendek masa ekspirasi. Makanya jangan 1:2. Kalau kita dewasa, kita bagging 1:2 kan. 1 detik masukin, habis itu 2 detik kita biarkan ekspirasi. Pada neonatus enggak boleh. Kita bisa dekatkan 1:1,5 atau 1:1. Ketika kita give the oxygen, kita kasih pressure ke dia, sebelum dia keluar semua kita tabrak lagi. Jadi PIP-nya dia biar bertahan. Karena yang otot horizontal itu enggak kuat dia ketika dia di GA atau di bius, dia hilang deh refleksnya. Jadi pasti kolaps semua alveolinya. Jadi kita harus kasih PIP dia dengan cara nabrak. Makanya berbeda caranya sama bius pediatri biasa. Maka kita minta yang senior yang bagging. Dia harus tahu dia enggak boleh menggunakan rasio 1:2 pada pasien-pasien yang preterm. Setelah itu, epiglotis. Bagaimana epiglotis bekerja? Kenapa sih epiglotisnya diciptakan panjang oleh Tuhan? Karena di akhir ekspirasi dia akan menutup. Tujuan epiglotis menutup adalah menciptakan PIP. Sama aja kayak tadi. Dan tujuannya semua bayi itu pasti dia menciptakan PIP diri dia, karena otot dada itu belum kuat dia untuk membuat pressure negatif yang cukup baik sehingga PIP-nya itu ditahan. Dengan epiglotis yang ketutup, itu fisiologi kalian intubasi sekarang. Begitu intubasi bisa nutup nggak? Tidak bisa kan? Nggak bisa tutup. Jadi dia loss aja kan? Jadi tangan kalian lah yang menciptakan PIP. Kalau kalian tidak bisa menciptakan PIP dengan tangan kalian, jangan bagging neonatus preterm. Gitu. Jadi harus tahu dulu fisiologinya apa. Ya, setelah itu ya kita tahu surfaktan, apalagi ditambah surfaktan kita tahu dia surface alveolar tension, dia mempertahankan PIP karena surfaktan defisiensi pada preterm jelas dia akan resiko kolapsnya lebih tinggi. Setelah itu oksigen konsumsinya dia 2 kali lipat metabolisme yang biasa kita 3 mili per kilogram berat badan, pada neonatus itu 6. 6. Dengan 2 kali lipat kebutuhan oksigennya, makanya rata-rata rate-nya 2 kali lipat. Kenapa sih nadi normalnya 120 sampai 140? Karena kita dewasa 60 sampai 70. Kebutuhannya dia 2 kali lipat. Ya tinggal kali 2 aja, 60 kali 2, 120. 70 kali 2, 140, 80 kali 2, 160. Makanya heart rate rata-rata mereka adalah 120 sampai 160. Karena 2 kali lipat kebutuhan, ya wajar tubuhnya dia mengkompensasi dengan heart rate dependent gitu. Jadi baseline-nya berapa ya segitu gitu. Oke, next. Kedua kardiovaskular ya tadi udah kita singgung juga, dia heart rate dependent, dia juga myocardial reserve dia ototnya dia belum mature, dia belum bisa membedakan mana kontraksi yang harus dikeras sama dia diringankan enggak, jadi dia konstan kekuatannya, jadi benar-benar ketika detensinya turun, ada hemodinamik yang stabil, dia akan merespon dengan heart rate saja. Jadi cardiac outputnya benar-benar heart rate dependent. Setelah itu ada perubahan sirkulasi yang tadi Uteroplacental di mana ada PDA yang berfungsi untuk membypass parunya. Sekarang dia berubah. Jadi yang awalnya flunya dapat besar, sekarang dia baru keluar, flunya itu masih terbuka lebar tapi nggak kepake. Jadi dia ada shunting di sana. Nah itu penyesuaian-penyesuaian itu harus dipikirkan. Sama tekanan darah gitu. Jadi tekanan darah itu berapa sih gitu. Jadi MAP-nya itu cukup rendah. Yang penting nggak di bawah 30. Jadi kenapa kalau kita wis pediatri yang kita pikirkan lah heart rate-nya dulu, bukan tensinya kan. Tensinya kita nggak terlalu peduli lah, tanda kutip lah. Padahal sebenarnya ada minimal 30. Selama dia berdenyut bagus, respon kardiaknya bagus, dia masih bisa takikardia, dia pressure masih cukup masuk ke jantungnya dia sehingga tenaganya masih ada. Itu simple ya berpikir. Oke, next. Nah ini saya bilang germinal matrix fragility itu ya. Jadi dia itu daerah di dekat ventricle yang merangsang pertumbuhan saraf-saraf neuron-neuron. Jadi karena Tuhan itu tahu dia otaknya harus berkembang, saya kasih pembuluh darah yang banyak. Cuma kelemahannya karena volumenya dia lebih kecil, otak dibanding ruang rongganya, dan di sini juga banyak pembuluh darah, maka risiko terjadi IVH itu cukup tinggi. Makanya hati-hati mindahin bayi. Jangan isi kepentok dari warmer ya. Jadi kita angkat warmer cetok di kepala dia, IVH dia bisa. Ya gitu, makanya jangan digoyang-goyangin. Jadi take care gitu loh, maksudnya harus hati-hati gitu. Habis itu autoregulasi. Cerebral perfusinya belum bagus, jadi dia tidak bisa merespon perfusi ke otaknya, jadi ngikut-ngikut aja. Kalau tensinya turun ya perfusi ke otaknya turun, tapi karena konsumsi otaknya belum sebesar kalian, itu masih mungkin nggak terlalu banyak kelihatan. Tapi kalau orang tua gitu, turun dikit, ya langsung tiba-tiba dia demensia, ada gangguan POCD gitu. Tapi kalau anak-anak dia lebih tahan karena konsumsinya belum terlalu tinggi. Setelah itu next, termoregulasi. Kita tahu semua termoregulasinya dia berdasarkan brown fatnya, dia harus metabolisme dulu, brown fatnya dia harus mengeluarkan suhu tubuhnya regulasi, enggak kayak kita yang lebih gampang meregulasi karena di otak kita termoregulator kita sudah matang. Sedangkan pada neonatus semakin dia muda semakin tidak matang. Jadi kenapa sih dia bisa hilang? Yang pertama adalah surface area. Ya, area dia lebih luas dibandingkan kita. Kepalanya lebih besar. Makanya kenapa sih untuk kita melihat kenapa sih bayi itu dipakein topi lebih penting daripada kita pakein yang lain gitu. Karena kepala surface area dia, kepala itu lebih tinggi berdasarkan radiasi. Ya ada konduksi, konveksi dan radiasi itu kehilangan panas tubuh pada pediatrik. Nah, setelah itu dia juga kulitnya. Dia masih tipis. Keratinnya belum banyak sehingga panas tubuh itu cepat hilang dengan radiasi. Subcutaneous fatnya juga rendah. Habis itu brown fatnya dia ya baru dia di atas 26 minggu lah baru dia bisa bekerja. Setelah itu juga volatile anestesi. Volatile anestesi itu inhibit non-shivering thermogenesisnya dia. Jadi sarannya gitu ya. Kalau kita operasi pediatrik itu sarannya suhunya itu di 25 sampai 27. Kalau saya pribadi saya masih bisa mengkompensasi sampai 23. Kadang operatornya kepanasan gitu. Tapi di bawah 23 itu agak sulit karena selain kita set dia operator roomnya, kita juga pakai warming blanket ya. Warm IV fluid, habis itu plastic wrap ya, yang masih saya kerjakan dengan plastic wrap. Kalau penghangat sekarang saya sudah jarang kecuali kita melakukan resusitasi. Kenapa? Karena siapa yang pernah pasang infus di sini, dipasang habis itu di loading, pasti dingin rasanya kan. Tapi kalau kita maintenance pasti nggak ada perubahan, karena cairan tuh masih bisa di kita tuh dia masih penyesuaian. Tapi kalau loading baru saya pakai IV warmer. Kalau kita nggak ada rencana loading, cuma maintenance, saya nggak pakai IV warmer. Yang penting yang saya pakai adalah set ruangannya berapa, warming blanket, plastik, udah. Itu aja yang saya kerjakan. Sama ya, ini harus ada temperatur ruangan, jadi biar enggak kira-kira juga ya gitu. Jadi kita lihat temperatur ruangan. Karena ini masalah yang spesifik. Nanti kalian kerja pasti sering ribut sama operatornya. Wih, panas sekali nih gitu. Lihat temperaturnya udah 32 dok gitu kan. Ya udah panas sih 32 ya gitu. Ya udahlah turunin gitu. Udah. Ini masih oke lah kita, tapi itu kan soalnya masalah panas dingin itu kan subjektif ya. Jadi kita harus ada hakimnya, itu temperatur di ruangan tuh harus ada. Ya, next. Nah, ini juga metabolic control glukosnya ya kita tahu di pediatrik, apalagi dia di preterm tuh rawan sekali terjadinya hipoglikemia. Penting sekali kita mengontrol GDS dulu sebelumnya. Kita harus bisa lihat bagaimana sih glikemiknya dia tuh, seberapa gula darahnya, fluktuasinya bagaimana sebelum kita memberikan stres pada pasien. Tapi rata-rata memang glukosa yang dihasilkan oleh pediatrik dari hepar itu nggak terlalu tinggi. Kadang kalau kita ketemunya dia tinggi, itu malah kadang-kadang dia mengalami stres metabolik. Apa sih yang buat dia stres? Bisa yang tidak terlihat itu adalah ROP ataupun IVH. Karena IVH kalau kita bayi itu dia IVH, TIK-nya naik, dia cenderung mengantuk kan. Jadi kita kira dia santai-santai aja gitu. Ternyata ada perdarahan di kepalanya gitu. Jadi makanya karena dia kemampuan untuk glukosnya dia jelek, makanya ketika kita memberikan IV maintenance pada pediatrik selalu menggunakan dextrosa. Ya, entah kita pakai D5, D10 gitu ya. Tapi biasa kita pakai D5. Yang kita mainkanlah di elektrolitnya D5 seperempat NS, D5 setengah NS. Kalau saya kemampuan ginjal yang belum matang mengeluarkan natrium, saya akan modifikasi. Kalau dia misalnya di bawah 3 tahun, saya akan kasih D5 seperempat NS. Di atas 3 tahun, saya pakai D5 setengah NS. Udah gitu ya, gampang hafalnya. Next. Obat-obatan. Nah, obat-obatan jelas. Hepar yang belum matang itu ya P450-nya. Itu belum matang. Setelah itu juga renal clearance-nya dia, GFR-nya itu baru 10% dia. Apalagi kayak usia 25. Bayangkan baru 10% orang dewasa. Even dia, ini jelek di preterm. Airnya banyak, dilusi dia banyak, sehingga volume distribusi itu lebih tinggi. Kita butuh dosis obat lebih besar. Kemampuan ginjal clearance-nya 10% dari dewasa. Jadi kita harus menurunkan dosis per-10-nya. Kemampuan dia mengeluarkan obat itu dia seper-10-nya, makanya obat itu akan terasa panjang pada pasien-pasien yang preterm ya. Makanya kalau bisa dikerjakan dengan regional, lebih baik regional. Itu ada kondisi-kondisi yang bisa dikerjakan dengan regional, nanti kita bahas. Next. Ini untuk pre-op-nya kemungkinan kalian sudah mengerjakan rutin, apa aja yang ingat pada pediatrik kita harus tanya gestational age-nya kapan, postmenstrual age-nya kapan, birth weight-nya apa. Nah, ini histori-histori yang harus kita ketahui. Ingat, kalau dia pasiennya dia preterm, kita harus tanya dia sempat enggak pakai support, ventilator setting gimana, CPAP gimana. Tanya HB-nya berapa, elektrod gimana, glukosa gimana, faktor koagulasinya gimana. Habis itu jantungnya. Dari kardiak apakah sudah evaluasi, ada kelainan jantung bawaan yang dibawa oleh pasien? Bagaimana dengan ductus arteriosusnya? Udah nutup apa belum, spontan apa dapat terapi? Setelah itu baru kalau bisa di echo, ada ekonya atau di ultrasound kepala. Kalau kalian curiga klinisnya dia enggak bagus, ada perdarahan di kepala. Sisanya, nih, ini yang buat teman saya di morbid dulu, syndromic phases, dia karena ngantuk, oka jam 2 pagi, pasiennya plus, enggak bisa diintubasi, ternyata pasiennya itu dia Down syndrome. Ada kelainan airway, nyampe manggil konsulen juga enggak bisa karena lupa ingat muka pasiennya. Karena kita pre-op banyak dulu kan, lupa kita itu yang susah. Jadi kita mainin aja dia preterm, kita mainin plus di UGD. Angkatan saya, teman saya ya, jadi itu yang dia salah. Kayak aku lupa ngelaporin bahwa ada sindrom Down syndrome. Jadi enggak nyiapin obat-obat apa, jadi masuk hajar, masuk LMA, enggak mau, tubasi enggak bisa nyari video laryngoskop, nah semuanya udah duluan UDIM. Karena yang nyoba adalah yang junior duluan. Kalau kita tahu dia sudah ada kelainan yang lain, kita harus nyoba yang paling senior aja langsung kan gitu. Tuh. Habis itu kita harus lihat dia di stres nafasnya tuh ada nggak tanda tachypnea, ada apa tidak. setelah itu turgor kulitnya bagaimana, kardiak murmur bagaimana, habis itu ini adekuat bukan asal tempel. Pastikan infusnya lancar kalau pediatrik. Jangan memulai apapun di pediatrik kalau infusnya tidak lancar. Itu kuncinya. Jadi kalau nggak lancar, jangan. Next. Ini resiko-resiko dari yang tadi saya bilang ada apnea of prematurity. Nah ini aja faktor resikonya. Yes, kita nggak punya sih kafein. Yang ini juga kita juga nggak gunakan. Tapi yang kita tahu kalau dia ada resiko postoperatif lebih baik kita bawa ke NICU. Nanti di sana diobservasi. Kalau memang ada apnea kita bisa support di sana. Kita bisa pantau dengan lebih baik. Tapi biasanya ini faktor-faktor resikonya. Next. Nah untuk goals anestesinya, kalau kita mau menciptakan robot junior kita, pokoknya bius pediatrik kayak gini gitu. Ya, pertama oksigenasinya 90-95, jangan dia sampai 100% terus-terusan. Ya, habis itu ventilasinya setting kayak gini, ideal volumenya 5, PIP-nya kasih 6, permisi per kapni, PaCO2 sekian. Cerebral MAP kita nggak bisa lihat, hipotermi yang penting dia sudah suhunya di set di 25 derajat, pakai bungkus, pakai plastik, tutup kepalanya, pakaiin blanket warmer. Setelah itu cek GDS-nya sebelum OK, durante, dan post. Next. Ya. Pilihan yang lain gitu. Selain dia general anestesi, kita juga bisa mengerjakan spinal anestesi. Mungkin ada beberapa teman yang udah punya kesempatan, Dr. Heriana, mungkin ngerjain juga spinal anestesi pada bayi. Setelah itu juga regional anestesi dan juga combine. Ya, combine ini sering kita kerjakan misalnya kayak kaudal. Kebetulan saya juga penelitiannya KL pada pediatrik sama PVB pada pediatrik. Jadi pasien laparotomi saya kerjakan paravertebral block yang di sekitar lumbar sama KL. Lebih bagus dia PVB durante op-nya, tapi dia durasi lebih panjang KL. Jadi yang saya gunakan bayi-bayi umur 6 bulan saya KL. Tesis saya dulu itu. Ya, next. Ya, jadi ini strategi untuk pembiusannya mungkin kurang lebih sama, jadi kita biasanya menggunakan ya gas, habis itu kita bisa kombinasi dengan ketamin, setelah itu atau tiopental, atropin, RW, biasa kita bisa pakai video laryngoskop. Sekarang kita punya yang CMAC yang lebih kecil, kita punya video laryngoskop lain juga yang ukurannya juga blade-blade-nya kecil, habis itu target ventilatornya kayak yang tadi, stabilitas hemodinamiknya kita lihat di heart rate-nya aja, karena kita jarang sekali lihat tensi dan sebagainya. Next. Ini dia, kalau dia spinal, kapan sih di spinal? Saya pernah mengerjakan gastroskisis, jadi ususnya di luar. Nah waktu itu nggak bisa intubasi juga, karena dia ada kelainan anatomi. Dokter gede dulu DPJP, dokter gede bilang kaudal ya, gitu. Jadi saya sungkup kaudal aja gitu. Jadi pasiennya spontan, kita tahu maintenance parunya dia kan susah. Kita harus buat PIP dengan tangan kita susah, kita biarin dia spontan, sedasi miring, kaudal. Main gastrokisisnya gitu. Selesai dia gastrokisis, nutup, udah tinggal matiin gasnya, bangun pasiennya. Gitu ya, bayi baru lahir tuh waktu itu di depan di UGD. Ya jadi kalau mau coba dia biasanya gitu, kita akan kerjakan dia di L5. Ya jadi di L5 antara L5S1 atau L4 L5 karena dia masih kita nggak bisa prediksi ya. Secara teori kan di L3 ya gitu berhentinya dia, tapi kalau dia lebih kecil lagi maka kita kalau bisa ambil di 5S1 biasanya kita pakai paramedian atau dari lateral. Kadang ada yang bilang L5S1 nya belum nyambung gitu, tapi kalau pada dewasa kan udah jelas dia menyatu. Next. Jadi intraoperatif monitoring yang perlu kita perhatikan dalam operasi-operasi neonatus saya rasa udah standar semua. Kita lihat tadi heart rate, kapnografinya, blood pressure, SpO2 2 ya, preduktal dan postduktal. Ya, preduktal di mana? Di tangan kanan. Ya, habis itu postduktalnya di yang bawah di kaki aja, kanan kiri pakai enggak apa-apa. Jadi kalau kalian memasang saturasi pediatrik di kanan dan kirinya berbeda itu otomatis kayak biasanya ada PDA-nya ya, atau ada shunting di mana. Tapi itu biasanya wajar kalau selisihnya nggak lebih dari 5, jadi biasa aja. Bayi-bayi baru lahir juga kalau kalian dapat SC baru lahir, periksa aja tangan kanannya sama tempat lain pasti berbeda. Oke, temperatur kita cek, glucose cek. Next. Postoperatif yang perlu dimonitoring itulah risiko apnea of prematurity 60 weeks PMA gitu ya, PMA. Jadi kalau dia tergantung lahirnya berapa minggu gitu. 34 minggu berarti sisa 26 minggu hidupnya dia, itu risiko apnea of prematurity-nya. Gitu. Kalau dia lahir bayinya 40 minggu dia lahir berarti sisa lagi 20 minggu atau 4 bulan gitu. 4 bulan kurang lah gitu. Tuh, jadi enggak ya usia yang 7 bulan dibilang risiko apnea of prematurity baru pasiennya prematur, umurnya baru udah 6 bulan itu kalian belum hitung PMA, bilang itu risiko apnea prematurity gitu. Jadi kita menghitung. Habis itu kita lihat respirasinya gimana, karena saya pernah bius laparoskopi pasien preterm lahirnya 32 minggu, ngerjain hernia laparoskopi cuma 15 menit, bangunnya 2 jam, nggak bangun-bangun dia pasiennya. Itu saya pernah. Itu ya, jadi ventilator dia bolak-balik, dia spasmo, udah matiin gas semua, spasmo bolak-balik karena responnya hyperreactivity dari airway-nya dia. Setelah itu juga dia mungkin sempat kolaps sehingga dia ada edem, begitu kolaps parunya, otomatis tubuh itu akan merespon dengan memfasilitasi bagian lain yang masih tidak kolaps untuk mendapatkan oksigen yang sama. Makanya pediatrik kalau obstruksi cepat banget terjadi edem paru. Nah, jadi diperhatikan juga. Analgesi dan juga nicunya. Next. Oke, dari saya mungkin tadi take home message-nya mungkin kalian lihat bahwa pediatrik itu bukan miniatur orang dewasa gitu ya, bukan dia tidak tumbuh gitu, tapi ada yang belum berkembang gitu, ingatin. Stabilitas berapa modal, ya apa yang dijaga, seperti tadi kalian harus kerjakan. Setelah itu yang perlu dicegah itu ada hipoksia, karena begitu hipoksia edema paru cepat, jelek banget, kita nge-extube susah setengah mati. Hipotensi, karena dia tidak bergejala hipotensinya dia, walaupun MAP rendah, kadang kita sering lupakan. Yang ketiga adalah hipotermi. Regional kalau bisa, karena kita tadi saya bilang obat-obatan itu dia kebutuhan lebih tinggi, clearance yang lebih rendah, kalau bisa dikombinasi dengan regional, saya rasa regional jauh lebih bermanfaat. Dan ketika kita lihat postoperatif, kita harus bisa menghitung berapa risiko apnea of prematurity-nya. Saya rasa itu dari saya. Terima kasih dokter semua. Saya izin.
Okay, so we already have 3 different speakers today. Now we will enter the discussion session first. So maybe I will open for 3 questions. If from the audiences wanna ask some question to maybe first Dr. Tjahya, Dr. Rita, and Dr. Anu Raju, please raise your hand.
Ayo, silahkan. Oh, silahkan.
Okay.
Bebas tanya apa saja.
Selamat siang, Prof. Doctor. My name is Lius. I'm from the residency of anesthesiology. Maybe I wanna ask to Dr. Hedita. Izin dok, yang tanya pakai bahasa Indonesia dok. Ini untuk bayi, terutama bayi normal dan bayi prematur tentu mempunyai ketahanan paru-paru yang berbeda. Seperti yang sudah dijelaskan dokter, memang kita untuk menghindari ya kita pakai autopip gitu ya dok ya. Nah tapi pada bayi, terutama untuk bayi-bayi prematur dok, berapa kira-kira PIP atau inspirasi maksimalnya dok yang boleh kita berikan? Kalau pada dewasa kan kita bisa nganggap 30-35. Kalau pada bayi, terutama bayi-bayi prematur ini bagaimana dokter? Apakah ada perbedaan juga? Apalagi kan kita khawatirkan barotrauma dan terutama juga volume traumanya dokter. Izin dokter.
Okay, thank you. Yeah, please Dr. Hendrita. Yeah.
Oke, terima kasih pertanyaan. Mungkin I will answer with Indonesia first. Untuk pemberian PIP atau berapa sih inspirasi maksimum pada kita berikan pada pasien-pasien yang pediatrik itu sebenarnya tidak ada batasannya. Kenapa? Yang pertama gini, kita enggak tahu prematur di sini berat badannya berapa, ya kan? Usianya dia berapa. Jadi beda sebulan, seminggu aja dia udah beda batasan maksimalnya. Tetapi dalam melakukan ventilasi pada pediatrik, gold standar yang dilakukan adalah kita melihat chest rise-nya dia. Jadi kita lihat dia seberapa ngangkat apa enggak. Karena kalau kita memberikan pressure, kita sulit sekali pada pasien pediatrik kita menggunakan pressure sebagai patokan. Kenapa? Yang pertama, cuff yang kita gunakan. Misalnya nih kita enggak hanya menyungkup, kita intubasi. Intubasi itu kita enggak pakai, kita gunakan uncuff ya kan. Kenapa sih uncuff? Karena dia menyempit di bawah pita suara ya, di trakea dia menyempit. Jadi kalau kita pakai cuff kita enggak bisa masuk di sana. Jadi kita menggunakan uncuff. Dengan uncuff itu dia berarti ada longgarnya kan. Ada yang bocor dari sana. Sebenarnya kita memberikan pressure pun dia pasti akan keluar. Tidak ada yang bisa pressure fix terbentuk dalam ventilasi. Makanya yang penting adalah kita melihat satu, kita lihat chest rise-nya dia bagus apa enggak. Yang kedua ETCO2. Tetap gold standar adalah ETCO2. Tujuan kita memberikan ventilasi adalah kita melihat ETCO2-nya. Gitu. Jadi pressure-nya berapa? Jadi kalau semakin kamu berikan, kita enggak pernah tahu nih berapa pressure maksimalnya. Makanya saya enggak menyarankan pemberian P inspirasi gitu pada pasien pediatrik, pasti susah. Gitu ya. Jadi karena dia maksudnya dia akan bocor. Ini nggak bisa, mesin itu nggak bisa baca pressure berapa karena dia pasti akan bocor. Yang kedua, kalau kita menyungkup gitu, kita sungkup, tergantung di tahanan dari abdomennya itu sendiri. Awal-awal kamu ngasihin pressure dia kecil, dia bisa masih masuk setengah-setengah kan, ke parunya masuk, ke gasternya dia masuk. Begitu kita agak lama ventilasi, gaster udah mulai kembung, udah mulai besar dia. Nah, itu menjadi tahanan juga. Jadi makin pressure malah lebih rendah karena udah sama nih, udah hampir equal dia pressure di torakal sama pressure di abdomennya. Karena udah isi udara, otomatis udara di ke perutnya lebih sedikit, jadi dia lebih banyak masuk ke parunya. Jadi kalau untuk menentukan berapa pressure kita supaya tidak barotrauma itu saya belum pernah baca, jujur aja ya. Karena dia memang nggak bisa diukur pressure-nya, karena kita menggunakan uncaf biasanya untuk pediatrik. Tapi yang gold standar adalah kita tetap menghitung target volume tidal masih menggunakan 6 sampai 8, kalau kita protektif kita taruh di 5. Yang penting kita kejarlah RR-nya. Makanya RR lebih sering dengan time inspirasi lebih pendek dan ekspirasi time lebih pendek. Gitu. Jadi kita membuat autopip di sana. Gitu. Ya.
Okay, is it enough? Okay, thank you so much for the question. We still have time for another question. Does anyone want to ask any questions to the lecturers? Our saxophonist maybe want to ask some questions. Okay, maybe I want to ask some question to Dr. Anuraju. So, as you said that the epidural anesthesia is the most popular, most common way for the birthing mother, right? In Australia, and maybe we see in the movie as well, like in the States, anywhere else. So, you've come to Indonesia plenty of time. Why do you think that it is still hard for us to practice it in Indonesia in our daily practice? And do you think how can we make it into our daily practices?
That's a very, very relevant and important question. I guess everybody in this room, like, who are doing anesthetics has the skills to do it. All right. So all of you, I'm sure you know how to do it. He knows how to do it. You know. All of these who are in the second or third year of training easily do an epidural, and that can be done for you. But for labor epidural, if you want to do it, who's going to give you the kit? Where's the money? All right. So ultimately, it comes to you have the skills. Everybody has the skills to do it. You can do it. Anyone. But unless and until you assure your what's it? BBGS, is it? BPGS. Unless and until the BPGS approves it, your insurance approves it, nobody is going to give you the money. Like, you are not going to shell your money from your pocket and do it, are you? So it is far away from you, your control. It's from the politicians. Has to happen from the top, and that's what people like Tjahya and all those people are fighting for. So they are lobbying at the level of ISMOAC, like, he's going to solo. There'll be lots of obstetric anesthetists coming down for the meeting, and of course they'll be inviting people from the government and all those things. The last time in MOAM, they invited people from BBGS to make sure that they come in, they know what the problem is, and there has to be lobbied. Unless and until BBGS releases money to you, your life is it's ultimately it comes down to money. And it has to happen. Is that you'd be having a bit more idea? And that's at least that's my own.
Ya, terima kasih Dr. Anu. Jadi kalau di Prof Murah kita sudah mulai coba pelan-pelan ya. Di sini sudah kita coba pelan-pelan. Tapi biasanya yang ada indikasi yang kelainan jantung. Tapi VIP sudah mulai ya. We will try VIP patient in the hospital, and then and then try to insurance government to cover appendix labor. Yeah, we will try. We must try. Yeah.
Okay.
So that's why it doesn't happen. You want to do labor analysis, you have to lobby for the government.
so I'm sorry, doctor. So if in Australia the national health insurance cover the epidural, okay, 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 Medicare, yeah, BPGS. Okay, thank you so much, Dr. Raj. Maybe another anyone else still want to ask some question? Maybe one more questions to the lecturers. Okay, so he wants to ask some questions. Yeah.
Okay, thank you. Sorry, my name is Adi. I want to ask to Prof. Anuraju. I would like to ask about the use of adjuvant in spinal anesthesia for obstetric surgery, particularly in pregnant patients. Is it acceptable to combine more than one class of adjuvant with the local anesthetic, for example, like dexmedetomidine, fentanyl, or dexamethasone, or the other else? From your experience, what are the key considerations regarding maternal safety, fatal effect, and the risk of neurotoxicity? Thank you, Prof. Anuraju.
All right, thank you. That's a very, very good question. I guess we try to keep things simple. So from I think all of us practice with minimal. So we just need to achieve an effect, isn't it? What we do is our adjuvants are not more than fentanyl and morphine. We put a short-acting opioid. So we have so our spinal doses is about 2.2, 2.3 mils of 0.5% heavy bupivacaine with 15 mics of fentanyl. That's 0.3 mics of fentanyl. So fentanyl is for immediate short-acting. It goes and attaches immediately to the mu receptors in the spinal cord. Doesn't cause any respiratory depression. That gives an extra modality of analgesia while we do the spinal anesthetic on top of your bupivacaine, your local anesthetic. And then we put intrathecal morphine. All right? So morphine is given almost 90-95% of patients. We get a long-acting opioid, which is lipophilic, not lipophilic. Fentanyl is lipophilic, that's why it goes and attaches. So this stays in the CSF and gives long-acting pain relief to about 16 to 18 hours. So our patient doesn't go on a PCA. They just go on regular Panadol, regular Voltaren, and this opioid would go for longer, and then we give some oxycodone as a rescue analgesia. So you can put dexmedetomidine, and what's the use? Like, if you can achieve these things with minimal effect, dexmedetomidine is known to cause very prolonged sedation. Same with fentanyl doesn't cause dexmedetomidine. People who use clonidine. All those things will prolong spinal analgesia, prolonged. But we can achieve this with minimal effect, with minimal side effects. There's no, of course, there are cases where you can use spinal analgesia. In pregnant patient, we tend to keep things simple to decrease the incidence of respiratory depression and sedation and other complications like itchiness and nausea and everything post-op. Our practice is just to use a short-acting opioid and long-acting opioid, nothing much. But if you look at the literature, there are lots of things out there, but this works for us, and we are just sort of sticking to it, because if you put more adjuvants, it's not going to add anything to what we are doing at the moment. That's what I think.
Yeah, so as Cassie was saying, you don't want a prolonged block, because that'll stop the patient moving around looking after the baby, and also might mean the urinary catheter stays in longer. And there's a good podcast by Ralph Laundell. She's a professor in Columbia in New York, and she's doing a study of using dexmedetomidine in the spinal. But she says this is experimental. All right, it's not standard practice. Experimental. So, like Arnie said, keep it simple. And they're doing the studies. So it's experimental, but they're doing a proper study on it.
Okay, is it enough? Okay, thank you so much, Professor and doctors, for the answers. Okay, so we still have two more speakers for today. We still have Dr. Kim and Dr. Cassandra, but before that, we will enjoy lunch first. Okay, yeah, it's, yeah. Yeah. So now, please, everyone, we can enjoy the lunch. Lunch is outside the room. So we will come back here in 30 minutes. So in 12:45, we will come back to the classroom. Okay, please enjoy lunch. Thank you. Okay, so good afternoon, everyone. Has everybody got lunch already? Okay, enak sekali ya. That means very delicious. So how do you like it, doctor? The Balinese? Is it okay? Is it too spicy? No, not too spicy. Okay, good. Okay, so as I said before, we still have two more lecturers for today. And now we're going to hear the lecture from Dr. Kim Osborne. Please, doctor, the floor is yours, and please give him a round of applause.
Thank you very much for inviting me. This is the fourth time I've been at this meeting, and the fifth, I went to another meeting in Bali, so I really enjoy it, and I enjoy your hospitality. And as we said last night, Cindy and the saxophonist, fantastic. Okay, so we better get on to the business of, yep, so I'm going to be talking about postpartum hemorrhage, but I'm going to focus a bit on in theatre, not the postpartum hemorrhage on the ward, actually in theatre, and how you might firstly prevent it, how you might pick it up, and how you might manage it. Now, I'm not going to talk too much about the specific of managing placenta previa, because I'm going to be talking more about emergency bleeding during caesarean. Oh, yeah. Oh, yeah, it does. Okay. Okay. Oh, we've gone too far. We've gone. Okay, so some of this talk is from the Federation of International Federation of Obstetricians, and that was published in October last year. So that's the most up-to-date one, which is really good. And then some of what I'm going to talk about is from the South Australian Perinatal Practice Guidelines for postpartum hemorrhage. So they're basically talking about vaginal deliveries. But so I'll just get on to the next slide. Oh. And as I said, we're talking about caesarean section. And when you look at this, you can see the hand is gone in, the obstetrician's hands, to get the baby out. So if you think about it, especially when they're deep in the second stage, the baby might be right down here in the pelvis. So they're more likely to cause tears. Or if they've been in labour for a long time, the lower part of the uterus becomes edematous, especially if they've had a previous section or several sections. So they're more likely to get tears. So that's just an example of, and what I mean by tears, they make the incision here, but sometimes the wound goes around the corner and they don't pick it up. Anyway, so this is quite a good diagram. We're talking about a framework because I've talked about what happens in the emergency situation, but it's good if we've prepared patients to minimise the effects of hemorrhage. And one of the important things I'm going to spend a bit of time on is talking about anemia. We're talking about recognising it, but also anemia and recognising it. And when the baby's born, everyone's all excited about the baby, but sometimes the obstetricians get a bit quiet. And if you're just on behind, you've got the draper, and everything's, you're chatting to the mum, but everything's a bit quiet and there's a bit of prodding around, and then you pick up your phone and you're chatting to the anaesthetic nurse. But what's important is especially when this happens, when the pulse starts going up and the blood pressure, so that's really, but also realise that this is 30–40%. So that's really bad. They've probably lost about 2 litres. And you need to be aware of what's going on and making sure you don't get to that. And I'll show, because I'm going to show some cases where that actually happened at my hospital. Anyway, so assessing shock. So we get on to anemia. Now the bit about anemia is, in South Australia, we have the perinatal practice guidelines, and they say our anemia rate is 8.7%. And that's at any stage in pregnancy. And in Indonesia, this is World Bank data. They say that the rate of anemia in pregnancy has come down from almost about 35% to 27%. But when I looked at this, so you got data and you've got data, I wasn't sure where this was measured from, whether it was measured from a middle class suburb of Jakarta, or if it was Aceh province, or Sumatra, or if it was Bali. So, but I presume what we can say is that it's improving in Indonesia. So I think, since I've been coming here, there are improvements. And the UNICEF, there's a thing about getting maternal nutrition. So at one of these meetings, we talked about nutrition, at one of these previous meetings. So there's a whole lot of work in Indonesia looking at how to improve nutrition, which would mean minimising anemia, which would therefore help in treating postpartum hemorrhage. So they've got developing guidelines. I mean, there are other things that we don't, like deworming during pregnancies, all these simple things, all these other things that occur. And also, just recently in Indonesia, the government's started this ambitious program of improving nutrition to children. Now, you're laughing about this. I mean, is it? Oh, no. So we were talking the other day, when I was at school, at primary school, we used to get free milk. We used to have the milk monitor. And then Jenny, one of the midwives, said she doesn't like milk because she's put off it, because she had to drink it at school. But that was an initiative we had in Australia years ago. But this is an initiative that's really good. But the other thing about it that I did find out, so there were some recommendations about anemia from FIGO, and it does include intravenous iron. So intravenous iron we use, but it does cost. And I said when I was at a meeting last year in Lisbon, I went up to the CSL lab, and I said, when's it coming off market? So it's going to be cheaper in the third world. Have you got any strategies to make it available in the third world or in Indonesia? Anyway, but getting the other things right is important. So one thing is, this is I didn't read this in full detail, but the bit about a women empowerment model for treating pregnant women at risk of anemia. So focusing on the women, because in Australia we've got a lot of focus on the women. And in addition, that's partly the thing about pain relief for labour. That's a woman-centric thing that women should be enabled to lobby for it. And if your government accepts, women having more of a say, and consumers saying we want these things. Because that's something that's occurred in Australia in the last 20 years or so. But it didn't used to be as much of an issue, 25 years ago. It's come in more gradually. Now, so the other thing we've talked about hemorrhage in an emergency, because this is the safety checklist. And in the safety checklist, there's all this bit about, is the bleeding going to be greater than 500 mils? Well, most sections do lose about 500 mils anyway. But really, you should be having a conversation, are there any risk factors for hemorrhage? You know, has a patient been in labour for 12 hours? Have they had a previous section? Is it a mouth? You know, some of those things that may be, is a patient anemic, that may make the risks of hemorrhage more likely. And that starts before you even put the knife, the surgeons have put the knife in or even put the drape up. So everyone's on communicating with each other about the risks. So here's a list of the pre-op considerations that you might need to make. I mean, we've had one case where it was an abruption, and the baby needed a lot of resuscitation. The baby died. Patient came in acutely, but no one sort of thought about, well, abruptions are associated with bleeding. And the next day, she had platelets of 40,000. She needed a transfusion. She needed to go back to theatre because people hadn't sort of talked to each other. And also, the other thing about the checklist is there's a bit at the end. You can actually talk to each other at the end about what your plan is. So that's those things. Now, just preventative measures. So we swapped over at caesarean sections from giving oxytocin, which lasts for about 10 minutes or so, to using carbetocin. So it's an analogue of oxytocin, and it lasts a bit longer. So it's the thing about carbetocin is that it's heat stable. So it doesn't need to be kept, or there are formulations of carbetocin that are heat stable, so it doesn't need to be kept in the fridge. So I know these are the other agents. It could be, this is for, that's a FIGO place where some hospitals in more outback areas may not have oxytocin, so they might be giving misoprostol. So that's an option, but it's clearly that takes a long time to work. So as I've said, they've got carbetocin because it's heat stable. Now, I looked about and saw if it's available in Indonesia, and someone has done a study on using carbetocin. So, but I don't know what the cost is of it in. And so the advantage of it is that it lasts for about 90 minutes. I'll just go, yeah. So carbetocin, time frame about 40, 60 minutes. Oxytocin's here. Misoprostol takes a lot longer to work. So this is drugs to use in the first, when the baby's delivered. So I'll just go back. Right, okay. So if you've got someone who's bleeding, then probably the first management, you'll be thinking about making sure the tone is good. So be checking with the tone. And I tend to just give small doses of ergometrin with an antiemetic, and also give some tranexamic acid, as well as remembering about resuscitating the woman. So you've got stopping the bleeding and also resuscitating the woman. So don't forget about resuscitating the woman and monitoring the patient, obviously. So we'll just get down. So then after that phase, you'll be wanting to talk about, with the obstetrician, about tone. Is there trauma, or is there a possible coagulopathy? Like with an abruption. That's an acute sort of coagulopathy. And I'll talk a bit about that later on. So that's looking at the, oops, what am I, oh, okay, right, okay, so I pressed too hard. So there are the various types of, when you talk about the 4 Ts, tone and trauma, so that those extensions that occur, and or uterine rupture, that they're the main things. So the other thing about treating tone, I've talked about using ergometry. Sometimes if there's more bleeding and it's a tone-related issue, we also give carbaprost, which is a prostaglandin F2 alpha analog, and that's given intramuscularly, and that lasts for about 45 minutes, and it can be repeated. So it's given intramuscularly. The other prostaglandin F2 alpha they used to put in the uterus, and that was an intense vasoconstrictor, and because it's much better, this drug is much better because it's given intramuscularly. So, and misoprostol is good for prevention afterwards because it takes a while to work. But don't forget about, if you're getting bleeding, giving tranexamic acid. And the thing about tranexamic acid, we sort of give it over 5 to 10 minutes. But also if the patient's still bleeding half an hour later, give more tranexamic acid. If you've got someone who's bleeding and you've given them a general anaesthetic, remember that if you're using volatile agents, they're, sevoflurane or whatever, they're relaxants of the uterus. So that'll increase the potential for bleeding. So I'd suggest converting over to intravenous total anaesthesia. So removing the volatile out of the system. I mean, acutely, when you've got an abruption, for example, you'll be just putting the patient off and putting them on volatile. But then afterwards, swap over. The other thing is, if things are getting out of control with regard, you've noticed the bleeding and there's a lot of bleeding, the obstetrician can always apply pressure to the uterus, and often that's required when you need to catch up with your fluids. Or if you've didn't realise that there's been a lot of bleeding, and you can get to that 4th stage of bleeding when they're almost arresting, we're actually getting the obstetrician to put a fist on the above the uterus on the aorta, actually decreases the flow to the uterus and then the blood loss. So we've had to do it several times, and you might do it at the perimortem caesarean section. You do it, and the obstetrician, and then put pressure on as well, up higher on, because that makes sure the blood flow goes where it needs to go and stops the bleeding from more of the uterus. So remember that about giving blood products. So you've got fractionated blood products here, haven't you? Yours is all fractionated, like your red cells, FFP, cryoprecipitate, or platelets. Yep. Okay. That's fine because that's what we've got. But we concentrated initially on the red cells and the fibrinogen, and then in obstetrics, the factor that goes down and is the most disadvantageous is replacement of fibrinogen. The fibrinogen level in pregnancy is high, and then it will fall with significant PPHs. So I'll just get on to that. So Anu's already showed you this. This is our algorithm for we use Rotem to diagnose if there's a coagulopathy, and we tend to use targeted treatment. Now, just going on to the other final one about thrombin. So we're now starting to talk about acute obstetric coagulopathy and resuscitation-related coagulopathy. So, and both of those will cause a PPH. So with an abruption, there may well be a coagulopathy. So there's all this blood clot behind the placenta that goes into the uterus and develops an inflammatory response. Or the other one is you're unfortunate enough to have a patient who has an amniotic fluid embolus. That'll cause an acute inflammatory response. And I've seen a patient where within a minute they've got all these hair spots. So that's caused an acute obstetric coagulopathy. And then the other ones, when you've lost about 2 or 3 litres, then it's more resuscitative coagulopathy. So just the next slide. So this one describes volume down here, no bleeding, this amount, over 3 litres. So there's a gradual drop-off of the various factors. But factor 8 actually increases, and then it starts to fall down after about 2.5, 3. That's actually procoagulant. So I think this was actually quite a good diagram to actually make you realise that even though you may do the correct factors here, they'll be normal. But then if you lose another litre, then that's when you're becoming abnormal, and you'll be getting bleeding from coagulopathy. Yep. So that's an important point to raise. And that's without the fibrinolysis. Okay. So I'll just briefly talk about some of the mechanical things that the obstetricians might do to stop bleeding. The Bakri balloon. Do they use the Bakri balloon here? Right. Okay, so initially they used to use a Senstarken tube, which was what they used to treat esophageal varices. So they started putting that up and then Bakri came along with the Bakri balloon, and then there have been some other modalities. So this is a UNICEF paper on the Bakri balloon, and this is an obstetrician in Burkina Faso in Central Africa talking about its use, because then it's put into the uterus, blown up, and it then tamponades the uterus to stop it, to decrease the bleeding. And obviously if it's still bleeding from then they need to, so often they might do that for a postpartum hemorrhage, but at section they could also do the same. And then the next thing that they do is do a suture, a B-linge or a Hayman or co-suture that then crunches down the uterus. And it doesn't crunch down the uterus, they're still able to have babies after this. So it just crunches, and it's mainly this one here, getting the arterial supply here and pulling down the uterus. So if that's from external, and then you've got a Bakri balloon inside, that's a really good method of stopping it, especially when it's associated with tone. But of course, if you've got a tear going around the back or down the vagina, that's actually not going to stop it. So that's when you need other operative procedures like doing hysterectomy, more likely. So just reminding about diagnosis of postpartum hemorrhage. about the shock index. So I'll just show, and then afterwards, of course, we've talked about giving people iron beforehand. Afterwards, in your management of the patients, remembering to give them iron and supplements afterwards. And that's where your IV iron is actually quite useful. I'm just going to quickly go through two cases that we've had at my hospital in the last year where there was a tear, and both of these occurred, at about 3 o'clock in the morning. And so the tears might be here, in the blood might go in the broad ligament, down here, or down here. So that's, remember, they're looking down here. So that's the uterus, and it goes, here. So just a reminder that when the blood pressure goes down, and you've done a spinal, and the blood pressure's going down 20 minutes after the spinal, and you're having to increase your vasopressor, you need to think, have a look, and talk to the obstetricians, and look in the bucket. It's actually where the blood loss is. Often at cesareans, we're using cell salvage. So the collection thing is right near us, so we can actually see how much is, if they're using the right sucker. Oh, that's just another little diagram. And the volumes, so this is for a normal 70 kilogram woman, but a lot of your women are smaller than that, might be pregnant with 50 kilos. So when you're talking about volume, it does need to be aware of these patients. And I wonder if picking up anemia in some patients with darker skin is more difficult than someone who's got paler skin. So that's something also we need to be aware of. So these are the cases. This is the case who she lost 6 litres and she ended up having a hysterectomy, and she had 2 previous sections, and the last one was 22 months ago. And the operative note then said high bladder, momental adhesions, noted lower segment. So she was booked at section to have her elective section at 39 weeks. And guess what happened? She came into labour at 39 weeks at midnight. So she was due to have a section later on that day, but she came in at midnight. And the registrar started the case, and because of all the adhesions, had to get the consultant to come. So all of that time, the patient's contracting. And then she delivered, and then the pulse rate went up and the blood pressure went significantly down. And sure, sometimes the pulse does come up, elevated when the baby's delivered, because the mother's excited to see her baby. But when you get blood pressure falling down and the pulse rate's going up after delivery, that's you don't, in that setting, you don't just increase the vasopressor. When you give more fluids, and you might need some extra help, and give your tranexamic acid. And I think what happened here is the consultant, my consultant, the anaesthetic consultant who was in the hospital, wasn't called till about this time. And at that point, they had to put pressure on the uterus, on the aorta, because the patient was about to have a arrest. And then she got blood. And then there's another anaesthetic chart here that shows the management. And she needed some cryoprecipitate because she got coagulopathic because she had 6 litres of blood loss. So, and was I mean, this is it's occurring in the middle of the night. Now, the other case was a really severe PPH, where the patient ended up having Sheehan syndrome. So Sheehan syndrome is when you get postpartum necrosis of the anterior pituitary, and it was described back in 1936 in Edinburgh, and they were doing autopsies on the mothers that were dying of hemorrhage, and they saw, oh gee, we're getting necrosis in the pituitary, and then women who were recovering after really severe hemorrhages, they were getting marked pituitary dysfunction. So that's where Sheehan syndrome occurs. So there's a website for patients that and describes all about Sheehan syndrome. So this patient, once again, she had 6 litres, and she was had received self-salvage, these blood products, and so she had her section, I think, about 3 o'clock, and let's go to the next one. She had a section here, and you can see that she's still on metaraminol, and the pulse at the end of the operation, her pulse is way above, and she got taken out to recovery on metaraminol. And they had to do another, and like always happens, they had to do another section straight away. So there was another patient section that had been waiting. But unfortunately, she remained in recovery with pulses like this, and then the poor recovery nurse, and she was on metaraminol. And then when they'd finished the surgery, they came out, and unfortunately the obstetrician was doing ultrasounds of the abdomen. I mean, she just needed to go back into theatre and actually deal with it. And anyway, so, and then the surgery took for quite a long time because they needed to get in another obstetrician, experienced obstetrician, to do the hysterectomy. And she was coagulopathic, and she was also significantly hypovolemic. But it's really easy for us to criticise, but also when you've been on duty for a long period of time, your brain doesn't always function as well as it, and sometimes having someone else, a fresh eyes, coming in and seeing the case, and that's where the new person came on. I think we called in the second on, and they had another case to do. So there was a lot of work going on that night. So there was clinical factors. So as a result of that, and we've had a number of cases where people have got worse in recovery because they've been bleeding in recovery after cesarean, and there's a bit of paralysis about who to call and pick up. And in the wards we have an RDR chart, like escalation of care. So we've got, this is what they are, and now we've developed another flow chart to help the nurses in recovery when they've got someone bleeding, how to escalate it during the night, during the day, and making sure if people are busy in theatre, who to then contact. So there's an escalation process, so we don't have any more patients like that. So, just what I've gone over, the FIGO recommendations, just remembering about trauma and where it can occur, and the escalation of and treating the various causes and types of drugs you can use for treating the tone, as well as stopping how the obstetrician can stop the bleeding acutely with pressure, or using a Senstarken tube, or a back creep balloon, or then actually just going on doing a hysterectomy. Okay, so thank you.
Thank you so much. And now we still have one more lecturers to go. So, last but not least, please welcome Dr. Cassandra. Yeah, please give her a round of applause.
Just while we're getting the slides ready, thank you so much for having me. I've chosen a topic that I hope will be relevant to all of you, specifically in obstetric anaesthesia, but just in everyday anaesthesia for other specialties too. I gave a very similar talk to anaesthesia residents in Adelaide back home recently, and they found it useful as well. So I think that, to summarise the topic, obstetric neuraxial interventions in situations where there's abnormal spinal anatomy is what I'll be talking to you about. So my goals today are to discuss with you a framework for assessment and decision making in situations where obstetric patients have abnormal spinal anatomy, and to summarise the key considerations in some commonly encountered pathologies. And why this matters is because, for a range of reasons, but patients often have questions and anxieties that they come to us with, and we need to have the information to address those. Patients have Googled things on their phone, their friends have told them things, and they come to us with many questions, and we need to have the answers. And we also need to know that some of the abnormal spinal anatomy can affect the safety and the efficacy of our neuraxial techniques too, with key risks being things like neurological injury, deterioration, failure of the technique, and medico-legal issues too. So how do we decide whether it's safe to go ahead and whether our technique is going to be effective for a given patient? And as always, history, examination and investigations are the main things that we need to do. So reviewing previous operation notes, if the patient's previously had spinal surgery, looking at the patient's back, palpating the landmarks. We used ultrasound yesterday, and that can be really helpful as well as any other previous imaging or new imaging if it's relevant in the situation. Discussing with a neurosurgeon if we need further advice. And it's also really important to document the pre-intervention neurological baseline too, so that if something changes after we intervene in the spine, we know that it's a new problem and not pre-existing if they already have some neurological symptoms. And these are the key questions that we need to answer with our history, exam and investigations when there is abnormal spinal anatomy. Are there landmarks that we can palpate, ultrasound, see or feel? Are there specific vertebral levels that are affected by this pathology, and do those levels therefore need to be avoided? Is there an intact ligamentum flavum for a loss of resistance technique, such as with an epidural? Is there tissue or surgical material in the path of our needle or catheter that will cause difficulties, or issues with the spread of local anaesthesia? And then also, this is a little bit of a separate issue, but does accessing the CSF carry specific risks in this patient? Other considerations are what our goals are. Are we aiming for analgesia, pain relief, or do we need surgical anaesthesia? Is the timing elective versus urgent? Are we under pressure to choose a technique right now, or do we have more time to investigate, discuss with patients, discuss with the multidisciplinary team? And what are the issues with alternative options? Is spinal or epidural safer for this patient? And are there risks of an alternative technique? If we're worried about the spinal anatomy, that doesn't mean that the safest option is to just do a general anaesthetic, because the general anaesthetic can have its own implications and risks, as we know, especially in an obstetric patient. They could have other comorbidities, a difficult airway. So we need to make a clear judgment about the pros, cons, and risks of what we plan to do. And as with any sort of neurological spinal issue, there's some red flags that should point you down a pathway of more urgent investigation. So if a patient has progressive deficits, sphincter dysfunction, severe radicular pain, or new numbness and weakness, then we should be escalating those issues and investigating further. And as I've said before, but I think it's really important to document the pre-intervention baseline so we have a comparison for later. So moving on to some specific pathologies and situations where we would be trying to make these decisions. Chronic back pain or lumbosacral pathology is really common. It's common in anyone, but it's common in obstetric patients. Lots of obstetric patients complain of back pain, lumbosacral pathology or pain during pregnancy. So how do we decide whether that matters and whether it changes our plan? So if we're talking about simply mechanical lower back pain, it's often exacerbated by flexion, palpation, and there may be radicular pain, but it wouldn't usually radiate below the knee. And the risks in this situation are very minimal. Neuraxial anesthesia will not increase the risk of postpartum back pain, which is something that I often get asked by patients. Is this epidural or is this spinal going to give me chronic back pain? The answer is no, the risk is not increased, but patients with pre-existing back pain are, separately to neuraxial intervention, at increased risk of having postpartum back pain in general. So it's important to separate those two concerns so that patients don't think that they shouldn't have a neuraxial intervention, and so that they later also don't blame the neuraxial intervention for their back pain. So in general, in this situation, neuraxial interventions are safe. Another scenario would be beyond just mechanical back pain, but disc herniation or spinal canal stenosis. This could present with low back, buttock, or leg pain. It's often unilateral, radicular, and may have radicular pain to below the knee. Could be associated with numbness, paresthesia, weakness, and can be exacerbated by certain positions. These are the types of situations that I'm talking about where it's important to document the baseline pre-intervention so that someone doesn't find that the patient has, numbness afterwards, and we start worrying about that it's related to the spinal anaesthetic when actually that was pre-existing. There are extremely rare reports of worsening neurology when patients have neuraxial interventions obstetrically in these scenarios, but it's rare, and there's no strong evidence to avoid neuraxial. If there is severe disease or symptoms, we do need to consider the risks and benefits, and that may just involve avoiding the affected level and having increased vigilance for neurological changes post-procedure. Another form of lumbosacral pathology would be spondylolysis or spondylolisthesis. As you can see from these diagrams here, sort of a progression of issues of those joints. This can present with low back pain exacerbated by extension. And there's no contraindication or increased risk with neuraxial in spondylolysis, but there may be slightly increased risk of dural puncture with an epidural technique in spondylolisthesis, given that the dura can be stretched at the level of the pathology. See here, this abnormality here can cause stretching of the dura, which alters your loss of resistance if you try to do an epidural. So both techniques can still be used, but once again, consider avoiding the affected level. And one way to achieve that is to use ultrasound to count and identify which level you're intervening at. Previous surgery in general is also can also prevent some issues. When patients have had surgeries such as discectomy, laminectomy, lumbar fusions, there may have been incisions and involvement of the ligaments, such as ligamentum flavum, which will affect loss of resistance if you try to do an epidural, and scar tissue, fibrosis. These issues can affect both your tactile feedback with your needle, as well as affecting how local anaesthetic spreads, particularly in the epidural space. So it's really important to confirm the level and the technique of the surgery and have an understanding of what is going on in that patient's back. Previous imaging or previous operation notes are really useful to get a hold of. It doesn't mean that we can't do neuraxial, but it is, again, safest or probably just most effective to avoid the level of the surgery if possible. Sometimes in these patients, you'll have a look at the scar on their back and aim to go above or below that, but acknowledging that that may extend beyond the actual level affected by the pathology or the instrumentation. So it's, again, still useful to look at previous imaging or operation notes. Scoliosis is another issue that can present really significant difficulties for neuraxial access. There are situations where it may be corrected, so at least the hospital that we work at does do paediatric scoliosis correction surgeries, and this can create big complexities later on for patients needing neuraxial techniques. Depending on what type of repair or fusion they've had, again, it's important to understand what the surgical technique actually was, to understand how it's going to have an effect on our choice of neuraxial technique, but it can result in significantly distorted anatomy. And once again, the scar is useful to know what levels are affected, but it's not always a perfect marker of exactly which levels are affected. And that's talking about corrected scoliosis. Obviously, there is also uncorrected scoliosis, and I think this is a good point to talk about the paramedian approach to a spinal. Have any of you used a paramedian approach to a spinal? If you just show me hands if you have. Yeah? A few people nodding? Yeah. So this is a really good option when your anatomy is challenging for a spinal anaesthetic, when there are calcified ligaments, deformity, or limited flexibility of the spine, because that approach will always give you an open space even to access the CSF, even if the patient is unable to flex forward well. So the insertion point then, as you probably know, is approximately here, so 1 or 2 centimetres lateral and caudal to the top of the lower spinal process of the space that you are approaching. And then you angle your needle upwards and inwards towards the space that you're trying to access in here. The needle path will just go through paraspinal muscles and then ligamentum flavum, and you're able to walk off lamina superiorly to find the interlaminar space if you contact bone on the way in. So a couple more diagrams of this approach. So as you know, your standard sort of midline approach here and paramedian approach. And so the space will always be open here, even if there is minimal space to access in between spinous processes here in the midline. So specifically in scoliosis, the advice would be to either, if you are going to go for a midline approach, you need to understand that this spinous process will give you an apparent midline, but that's not actually the midline that corresponds to being able to access the CSF. So if you are going to use the spinous process as your sort of insertion point, then you need to point your needle towards the convexity of the scoliosis. So the needle needs to come in from this direction to be able to meet this trajectory, because if you think that this is midline and you approach in this trajectory, you just get bone and you don't get into the space, right? Alternatively, a paramedian approach, if you find the apparent midline of the spinous process and then move paramedial to the paramedial approach here and angle your needle straight, then you would hopefully be able to access the space from this approach. So those are sort of two different ways to look at things. And as I said, angling towards the convexity, if you're using this approach, is the key. So understanding what the curvature of the spine actually is. And I think we've got a good example here where Anu has marked the spinous processes. So you can see the curve, have used ultrasound to establish where the landmarks are for both midline and the level for the approach. And then if you look here at the trajectory of the needle, because he's marked out all of this information here, then we know that hopefully, I assume it worked, Anu, we will find the CSF that way. Do I still have a few more minutes? Yeah. So there's a few other situations that we can still talk about. Spina bifida is one example, but as you know, it encompasses a range of birth defects of vertebral arches, spinal cord, and meningeal structures with varying degrees of sensory deficits, with or without issues like tethered cord, abnormalities of the epidural space, and lipomas. Some patients have surgical repair of these, but that doesn't mean that there's still not tethering of the cord, and it can be associated with other issues such as scoliosis and Arnold-Chiari malformations. So this is a situation where you really need to be clear on exactly what pathology the patient has and at what level, so that we can understand what the risks of a neuraxial technique would be. The risk being damage to the cord at the level of a repair or tethering. So presence of a tethered cord, of a posterior tethered cord, is an absolute contraindication to neuraxial, because you could damage the cord with your needle. But in these situations, MRI is really useful to find the level of the termination of the cord, presence of tethering, and assessment of any other issues in the potential path of a needle for neuraxial technique. Ideally, once again, we would avoid the level of abnormality or the repair. Neuraxial could still be possible above the lesion in selected cases where we have all of this information available. Acknowledging that there could be unreliable spread of local anaesthetic due to scar tissue, epidural space abnormalities, and unreliable loss of resistance as well due to abnormalities of the ligaments, which then increases the risk of a dural puncture with an epidural. This flow chart sort of summarises what I've already talked about in terms of the questions that we need to ask ourselves in deciding what we're going to do about neuraxial in a patient with abnormal spinal anatomy. And this is from a really good BJA education article on obstetric neuraxial techniques in patients with abnormal spinal anatomy. So I'd encourage you to have a look at that. It's very helpful. The last thing I was just going to touch briefly on is Chiari malformation, which I suppose is not strictly an abnormality of the spine, at least not the lumbar spine, but it's still useful to talk about and think about, because we do see these patients relatively often, at least in our hospital. This is a group of disorders of anatomic abnormalities of the cerebellum, brainstem, and craniocervical junction, causing downward displacement of the cerebellum and the medulla. And it can present with headaches, neck pain, other neurological features, and abnormal CSF flow dynamics. There are four main types. The one we would most commonly see would be type 1, which is a herniation of the tonsils, but not usually with more severe issues than that. The risk here is that changes in CSF pressure with dural puncture could cause herniation, which means that in a patient where we're concerned that there's raised ICP, it's an absolute contraindication to accessing the CSF. And these patients also, if they did have dural puncture from an epidural, it may prevent in a more severe or atypical way as well. The practical implications here are that we really do need to understand what the symptoms are, see what imaging the patient has previously had, and ideally get a neurosurgical opinion on our approach. If the patient's asymptomatic with no stirrings or concerns about raised ICP, we can usually still do a neuraxial technique, but we need to be cautious with a low threshold for escalating if we think that there have been neurological changes. Again, reiterating how important it is to know what the patient's symptoms and baseline are before we instrument the spine. I think that's about it from me. This is just a little summary of those key questions that I talked about right at the beginning. For any of these situations, I think these are the important questions that we need to be able to answer before we can be happy to inject something into the patient's spine. Are there landmarks? What level is affected? And do we need to avoid that level? Can we do a loss of resistance technique? Is there obstruction in the path of our needle or to the flow of local anaesthetic? And would accessing the CSF present risks such as in the Chiari malformation situation? And that's it. Thank you.
Thank you so much. Thank you so much, Dr. Cassandra, for your lecture. So that wraps up all our 5 lectures for today. And now we enter our last Q&A session. Due to the limited time, maybe I will open 1 or 2 questions for this session. Does anyone want to ask some questions to our lecturer? Anyone? Oh, okay, please.
Good afternoon. I'm Onek. I'm one of the junior residents in anesthesiology in Fakultas Kedokteran Universitas Udayana. So I would like to ask from Dr. Cassandra, or maybe other speakers could also have some addition from the answers. I would like to ask, during the procedure of neuraxial anesthesia, there would be some complications that we could find, and in doing so, there would be failed attempts that can occur when we do the neuraxial anesthesia. Might be from the patient anatomy, from what you have explained, from the history of the operation that has done from the patient, and also other anatomies like scoliosis that would be a factor, one of the factors that could make a failed attempt to the procedure. So I would just like to ask, based from your experience from those failed attempts, how many times or how many attempts that are acceptable that we can do to the patient in doing neuraxial anesthesia, so we can also think about the comfort from the patient, and also not to prolong the time from the duration of the operation. And maybe I would like to ask your backup plan when in doing the neuraxial anesthesia when this happens. Thank you.
Thank you. That's an excellent question. So the first part of the question being how many attempts do we persist with before we abandon the technique? And you made a really good comment that the patient's comfort is really important, as well as timing. I think firstly, before, if you have someone with abnormal spinal anatomy, and I should have mentioned this, but we should counsel that patient that it may be difficult to do a neuraxial technique, and be honest with them that this may involve them sitting there in a bit of discomfort in order for us to do it. And it's important so that they understand what is happening, but also so that we can understand what their priorities are. Some patients really want to be awake for their surgery. Some patients don't really mind and they just want to be comfortable. So having that conversation, that honest conversation with your patient about what the goals are, I think is really important. In terms of how many attempts, I think we can't put a number on it, but it's a combination of the patient's motivations, their priorities, their comfort and their tolerance. Some people tolerate it really well and they're calm. Some people get really distressed, and we have to make a decision sometimes for them that what we are doing is no longer appropriate. I think with each attempt, with each pass of your needle, you need to feel like you're gaining more information, more of a picture in your mind about what is going on and anatomically. If you are blindly passing a needle, hitting bone, not hitting bone, and not gaining any information with each pass that's helping you to progress what you're doing, then I think it's reasonable to stop, get a more senior or just alternative pair of hands. But absolutely, if you are just passing your needle in and out of the back and sweating and getting anxious and the patient's getting anxious, it's not productive. And while it's really good to do an awake technique for a cesarean section, it's not the end of the world to put a patient to sleep. Yeah, that would be my answer. Also, if you have like a timer or you look at the time when you start so that you don't lose track, because sometimes you think it's been 5 minutes, it's been half an hour of trying, right? So having a situational awareness as well. Yeah.
Okay, is it enough? Okay, thank you so much for the answer. I think we still get one more questions earlier from this side. Okay.
Okay, thank you for the time. Probably the question from the Miss Dr. Cassandra. This I have is experience for the patient with the cherry malformation before. Is the type 1 of cherry malformation. I have the patient. This one for the C-section of the operation. They have the one problem for this one, and they must to emergency of the C-section for the before. Our anesthesia, yeah, emergency C-section. Okay, our anesthesiologist, this one to choose the epidural of the anesthesia for the condition of the patient because they have type 1 of cherry malformation. But I searched several like the literature for this one. If not have the fixed option for the condition, if we doing the anesthesia for the condition like this one. Is your experience for the anesthesiology? Which one of the choice of the anesthesiology for the condition of the cherry malformation for this one?
Okay, So what would be my plan for a Chiari 1 malformation patient? It depends. And so my approach, or our approach would generally be to have a history of, has the patient been seeing a neurosurgeon? Have they had any correctional procedures? What are their symptoms? Have their symptoms been worse in pregnancy? Do they have any symptoms of raised ICP? If they have seen a neurosurgeon, that's great. Have they had an MRI recently so that we can tell whether this is stable, whether it's changing over time? And ideally we would talk to the patient's neurosurgeon who they've seen and get their opinion on whether they think a neuraxial intervention is safe. So I'm not sure if it would be a different system for you here, but that's what we would generally do. I think if you're in a situation where it's an emergency and you don't have the option to get all of that information, then it's really challenging to make a safe choice. I think you have to be aware that if you do have a genuine concern that accessing the CSF would be unsafe, then you have to be really cautious with your epidural choice, because you can still get an accidental dural puncture, right? So even though an epidural is avoiding the CSF, 1% of the time it's not, and are we willing to accept that risk? So in a situation where we don't have a clear history, recent imaging or opinion from the neurosurgeon, I think we would have a fairly low threshold to do a general anaesthetic, but I'll see what my consultants think as well.
Totally agree. I think from in Australia, most of these patients will be seen by neurosurgeons, and they are the best judge. And we are just seeing them just from the pregnancy and stuff. They've been seeing this patient. Neurosurgeons know these patients. They know how severe this procedure, the severity is. So it's always worthwhile getting an opinion of the neurosurgeon. So we see, as Cassie has said, we see Arnold Chiari malformation quite often. And most of these patients will be seen by a neurosurgeon, and we get their opinion. So these patients will be referred to us early in pregnancy. We got a high-risk clinic, and the obstetricians are very good. They get referred to us, they get seen. So we got time to make sure that the patient is followed up, and we got a plan. And we discuss these patients in our department in a high-risk meeting. So that some of the neurosurgeons say, that's all well corrected. I'm not worried. Don't do a spine. And some of them, they say, don't do any neuraxial. The neurosurgeons would say, don't do any neuraxial. Because as Cassie has said, you can get away with an epidural, but what happens if you puncture the dura? Still can happen, isn't it? 1 in 100 of times, 1 in 300 of times, you can puncture the dura, and that causes more harm than doing a spinal with a 27-gauge needle.
Chiari malformations can be associated with scoliosis, which could make your spinal or epidural technique more difficult, which could increase your risk of a dural puncture as well. So it's not without risk.
Okay, I think that's enough for our, is it enough? Okay, I think that's enough for our Q&A session. I think, because after this we still got the ceremony together with the OBGYN and pediatric at the 5th floor. Okay, maybe so that's all today for our guest lecture for the 13th BICCM 2026. Please give a round of applause once again for our guest lecturer and our lecturer. So now we would like to invite Dr. Tjahya to give the souvenir for our guest lecture. And we will like to invite all our guests and Dr. Herita as well to the stage, to the front. This is Dr. Anuraju, Dr. Kim, Dr. Asbar, and Josephine as well. We would like to invite you guys to the stage. Okay. Take picture. Yeah, maybe if you want to just. Yeah. Okay, let's take a picture first, and after this, all of us here will take a group picture at the front. Okay, look at the camera. 1, 2, 3. Okay, once more. 1, 2, 3. Say cheese. Cheese. Okay. Oh yeah. Okay. And now we'll take a picture. All of us together. Berdiri aja. Kita semuanya dari depan, nanti di fotonya. Jadi kelihatannya ke belakang. Mungkin merapat juga ke bagian tengah ya. Yang di belakang boleh maju biar kelihatan semuanya di depan ya. Okay, 1, 2, 3. Once more, 1, 2, 3. Okay. So, for everyone here, thank you so much for attending the guest lecture of